I think let us all mute ourselves now.
Yeah.
Yeah.
Just waiting for, yeah. Hi, Dr. Gulani.
Hi, good evening. How are you?
Hi, good evening. Very good, very good. Great to see you. So, Dr. Luthra has joined, no? Vardhman, what was Dr. Luthra saying?
He was saying he's joining in 1 second. He was already in the process.
Okay.
He's just asked for the link on group. I just
Very good. Great to see you. So, Dr. Luthra has joined, no?
About 6 a.m. and I'll follow up.
Vardhman, what was Dr. Luthra saying?
No, he was saying he's in the process. He's in the process
Okay.
to log in. So he said he will be online in 1 second.
So, Vardhman, your screen should be ready, huh? So we'll.
Yeah, my screen is ready. My presentation is ready. No issues with that. Yeah.
Okay. So I think, Rahul, you can start please on Facebook and YouTube also.
Yes, sir. Started.
He was saying he's in the process. He's in the process to log in. Yeah, I think Gaurav is online.
Okay. So, Mr. Rahul, just mute everybody, please. And you also keep your microphone muted, Mr. Rahul, and yes, yeah. Okay. So I think, Rahul, you can start please on Facebook and YouTube also. Somebody's Facebook audio is on, I guess. It's giving a, feedback. Rahul, it's on.
Yes, sir. On.
Okay. So good evening, everybody. On behalf of Rajasthan Ophthalmic Society and Maharashtra Ophthalmic Society, I take great pleasure to welcome all of you in today's international webinar on how to tackle nightmares in cataract and refractive surgeries. So today we have a galaxy of speakers with us who will take us through some of very interesting videos of cataract and refractive surgery. So before we start our program, I request President of Rajasthan Ophthalmic Society, Dr. Rajkumar Sharma, to please say a few words and welcome everybody. Dr. Rajkumar Sharma.
Thank you, Harshul. And I again welcome you all from ROS side and on the behalf of MOS or the Maharashtra Ophthalmic Society also. I think this is going to be a great event where Dr. Gulani from Jacksonville, Florida will also be sharing his videos. And I welcome Dr. Sunaina from Aurangabad, who is the chairman of the president of the Maharashtra Ophthalmic Society. I also welcome all other dignitaries like our secretary, Dr. Sandeep Vijay, the guests, Dr. Harshul, you have already met, and the stalwarts from Maharashtra Ophthalmic Society who will be participating. I just wish great success to this webinar and wish that all of us learn a lot, especially the cataract and refractive surgeons. Over to Harshul for proceeding.
Thank you very much, sir. Thank you very much. And now I'll request President of Maharashtra Ophthalmic Society, Dr. Sunaina Malik ma'am, to please welcome everybody and say a few words.
Namaskar. I welcome all those of you who have logged in, not only from India, but internationally to this wonderful webinar, which is the first of its kind, interstate webinar. And I thank the Rajasthan Ophthalmological Society for joining us in this. I think it's a unique venture, and I hope there'll be more to follow. We have a glittering galaxy of speakers, and I'm sure this is going to be highly interesting. So thank you so much, all of you.
Thank you very much, ma'am. Now I'll request our Secretary of Rajasthan Ophthalmic Society, Dr. Sandeep Vijay, to please come in and say a few words. If you can put Dr. Sandeep Vijay on screen, please. Dr. Sandeep.
Good afternoon, everybody.
Yeah.
Welcome to this international webinar, which we are organizing in association with the Maharashtra Ophthalmological Society. And we have a stalwart of speakers in this webinar, Dr. Vardhaman, Dr. Deepak, Dr. Somil, Dr. Sonu, Dr. Gaurav, and Dr. Samresh, Dr. Saurabh, Dr. Zainin, and over and all Dr. Arun Gulani from USA. So this is going to be a wonderful webinar, and we all are going to benefit it a lot. And I welcome again all the dignitaries of this webinar. Thank you very much.
Thank you very much, Dr. Sandeep. I'll request quickly the Secretary of Maharashtra Ophthalmic Society, Dr. Vardhaman, to please say a few words before we start.
So, hi, good evening, everybody. And first of all, I would like to thank Rajasthan Ophthalmic Society, Dr. Harshul, Dr. Sharma, sir, and Dr. Sandeep and their team for being associated with MOS in this event. And I believe currently the most popular elective surgeries around the world are cataract and refractive surgery. And we are going to deal with certain management issues of nightmares and complexities that all of us want to deal with in our day-to-day basis. And we want to come out as a winner. So we have already seen, we have excellent array of speakers, and I think here we start with our webinar. Thank you.
Thank you very much, Dr. Vardhaman. My counterpart, Chairman Scientific Committee of Maharashtra Ophthalmic Society, Dr. Preetham, quick word from you before we go on. Yeah. Dr. Preetham. Yeah.
Can you hear me?
Yeah. Yes.
Yeah. So I'll keep it short. I think extraordinary times require extraordinary measures, and webinars is the best way to reconnect on our academic platform again. So I welcome all the speakers today. I welcome Dr. Arun and all our friends from Rajasthan, Maharashtra, India, and all over the world. We are going to have a fantastic evening with great academics. So let's begin.
Yeah, thank you very much. So the first speaker for today's evening is Dr. Vardhaman Kankaria, who we all know is Secretary of Maharashtra Ophthalmic Society, is Director of Asian Eye Institute, Pune, and is a very affectionate, humble human being. And he has to his credit many youngest awards, like he's the youngest surgeon to own and to start SMILE. He's one of the youngest MOS secretary. He has won innumerable awards in India and international platform. An amazing surgeon and a great friend, Dr. Vardhaman, with his first presentation.
Thank you, Harshul bhai. So I'm going to share my presentation now here. Is it seen? Is it in the sharing mode? Not yet, right?
No, not yet. Yeah, it's fine.
Okay. So I think all of us are going to make quick 5-minute presentations, which are going to be followed by 5 minutes of discussion. First case I'm going to show to you all is in refractive nightmares. We all know that SMILE is currently the most minimally invasive surgical procedure available today in terms of refractive procedures. So this is a story of a 35-year-old male patient who was referred to us with the chief complaint of gradual painless progressive diminution of vision in his right eye. In the left eye, he was doing very well, and he had undergone smile procedure elsewhere about 3 months ago. So he couldn't go for the follow-up to his operative surgeon because this patient was working in Pune and the surgery was done elsewhere. So his operative surgeon had referred this patient to me for evaluation. And when we saw him, we saw that actually the left eye was doing brilliantly well, but the right eye was actually seeing only 6/36 best corrected with a very high mixed astigmatism. If you look at the slit lamp photograph, you will notice that in the interface, there was epithelial ingrowth, which was about 2 to 3 millimeters. There were confluent epithelial cells in the central visual axis, and there was no extension. That was very important to see, that there was no extension to the peripheral small incision. So it was almost like an implantation of the epithelial cells during the surgery. So this was very important for us to see. We got the OCT done. You can see this confluent cells here. You can also see in the central zone the epithelial ingrowth and the kind of impact it has on the corneal topographies, causing very high irregular astigmatism. So first and foremost, we wanted to actually understand what is the mechanism of this ingrowth. Typically, the ingrowths which we see in LASIK are progressive epithelial ingrowth, which starts from the incision, goes in the interface. But here in SMILE, it can happen also with the first mechanism, but second mechanism is what was more of a possibility in this case, in which there was loose epithelium at a SMILE incision, which was noted by the primary surgeon when we had done the procedure, when I had a discussion with him. But now there was no epithelial fistula. So that means it was an isolated epithelial ingrowth in the visual axis without a connection to the SMILE incision. So if this is the scenario, definitely there are two different scenarios which have been already described in the literature. Either you can go through the original small incision and then debride, which is a very big challenge here because you don't have access, full access to a very small incision to go into the interface and remove the epithelial cells completely. So this approach was not possible. And the second one is use of very low intensity YAG laser, but this is known to cause scarring in the interface. And this being in visual axis was not the right solution. So basically, as Thomas Edison says, whenever we have to go beyond, we have to think about the new things. And we already knew that there was this circle software which was used for therapeutic use for enhancement purpose after SMILE. So if there was a residual error, we used to convert the SMILE into a flap and then do the laser and put the flap back. So we thought that to have the full access in the interface, now it was necessary for us to convert the SMILE into a flap. And that's why we created this circle software. The circle software basically has three important incisions. One is the lamellar cut, which is at the same level as the SMILE. Then there is something called as a junctional cut, which makes sure that the previous interface of the SMILE and the periphery of it kind of coalesces together. And then there is a vertical side cut, which creates the side cut of the flap. So I will show you the video now. You can see that this is the lamellar cut, which is beyond the SMILE lenticule, which is created. Now this is the flap cut which was done, and I'm going into the interface. I'm making sure that the dissection is atraumatic. I'm going beyond this area of the epithelial ingrowth that you can see here. And once I go just beyond it, I open up the flap, and then I'm going to invert the flap up so that you can see this gel-like confluent cells, epithelial cells, and I'm going to debride them. Once the debridement is done thoroughly, we have to also make sure that it is also done from the undersurface of the flap. You can see this epithelial confluent cells, and this is done from the undersurface of the flap. And once that is done, we used a bit of mitomycin C, and then we put the flap back in its position. So basically, through this creation of the side cuts, we could actually have the access to the same interface. This is the slit lamp attachment to the Visumax, in which we could actually see now there were hardly any epithelial cell nests which were left behind. So you can see from the pre-operative to the post-operative, this is the first day actually post-operative. You can see there is a very big difference, and now the patient has improved significantly better. If you look at the topographies from a very high irregular astigmatism, we have actually improved it to very, very significantly better corneal topography. So first and foremost, take-home message is that progressive epithelial ingrowth can happen even in SMILE, but it is important to know the mechanism. As we discussed, it can be intraoperative implantation, like in this case, or it can be a progressive post-operative through the epithelial fistula, which will actually require a small incision access to it. And this is a new modality of use of circle that we have actually described, and this is soon going to be published in JRS. Thank you very much.
Thank you very much, Dr. Vardhan. That was a very innovative way
Yes.
to tackle the epithelial ingrowth after a SMILE. So what is the incidence of like epithelial ingrowth in smile as such in literature?
So literature actually has shown that if we look at very big series, so there is a very big series from China, which was 1,500 cases, and they have seen epithelial growth happened in about 15 of them. But all 15 were innocuous. All 15 were at the age of the incision, and they did not progress.
If you can
so if you
stop
look
the
at the
sharing.
progressive epithelial growth, which required intervention, oh yes, I will do that.
Yeah.
Yeah. Is that okay? Yeah. So if
Yeah.
we look at the progressive epithelial growth in the literature, there is one report from Bangalore where they actually tried to debride it from the small incision, but it was not successful. So they had to create another incision at the very close to the epithelial growth, and they used a sealant to close the epithelial fistula. So that was a different mechanism because that was through an epithelial fistula. In this case, it is presumably through the implantation during the procedure. So that's why I think this thing worked very well. Now we have more than a year of follow-up of this case, and there is no recurrence at all. The patient is doing very well.
Okay, so I'd like to call in here Dr. Gaurav Luthra, Dr. Arun, and Dr. Sonu, who are also doing smile procedure. If they can join in the discussion. Dr. Arun?
Yes.
If you can unmute yourself, please.
Hi, yeah. Harshal, Gaurav here.
So, hi, Dr. Gaurav.
Yeah, nice to be with you. Thank you for inviting me, and hello, Arun, and everybody else, all the office bearers and all friends. So I think Vardhaman has showed a very, very interesting and very innovative way of clearing, because it was in the central area. Now, typically in Smile, I've been doing about 3 years now, and we don't get to see epithelial ingrowth usually in the central area like he saw. This may be a unique case. We would normally see it starting from the Smile incision. And sometimes that happens only when you have some damage to the smile incision during surgery, if you've held it with a forceps or something, or for some reason if there is a loose, that small incision is loose. So this is unusual, and he was able to innovate and actually do it so well. And I would do exactly the same thing if I've had 2 epithelial ingrowths in about 1,000 plus eyes now, and they were both innocuous and they did not progress. So I did not have to intervene. There was one patient we had done right in the beginning, which was more like a pseudo smile, where we had almost a 180 degrees incision, and that patient had a flap dislocation. I mean, had a kind of a thing right in the beginning. On day 1 itself, we had noticed a flap, dislocation, and we had actually done a wash at that time. That patient went on to get an epithelial ingrowth, and we had to intervene. So, but that was like our first or second case, and we had done a pseudo smile. So otherwise, smile is very, very unlikely to get epithelial ingrowth. So it's a very rare complication as compared to LASIK or femto LASIK.
Dr. Arun, would you like to add something?
Yeah. Dr. Harshul?
Yes.
Yeah.
Sorry.
So I think I also have not experienced this epithelial ingrowth, but I think one of the things I think I would like to ask the other panelists, whether keeping the cornea too dry can increase the risk of these kind of things, because it may lead to epithelial detachment at the edge, and then it may go inside. So keeping cornea a little bit wet while dissection is a better idea.
I think sort of if we have the cornea very dry, definitely there is slightly higher chance of decussation at the margin of the incision, and also sometimes the incision gets slightly everted if you have seen in very dry. So I think the point that you're making does make sense, and it is always better to have slight moist cornea when we are doing both dissection as well as the application.
And also when there is a epithelial defect towards the cornea from the incision, I think better to keep a BCL, bandage contact lens, so the chances of epithelial ingrowth will go down.
Yeah, that's true. Actually, the ones which have been currently described in literature at the incision have been highly innocuous, as Dr. Gaurav has just said. This one, when I spoke with the primary surgeon and he looked at his surgical videos, basically there was a bit of loose epithelium at the incision. So maybe it got implanted at the same time. But definitely, if there is epithelial ingrowth during LASIK or during SMILE, definitely we should put a BCL in place, for sure.
Wonderful video, Vardhaman.
Okay.
Dr. Sandeep, you want to make a comment?
Yeah, Vardhaman, you are talking about the circle software. So whether this software comes with the machine, or focus some points on this circle software.
Sure, sure. So, Dr. Sandeep, Circle software is basically a specialized software which has to be bought from the Carl Zeiss as a license, the way we buy the Smile licenses. And this is the one which is currently FDA approved for enhancement purpose. So basically, as I've said, if you want to create a flap and then enhance, we have to use it. The purpose of during this epithelial growth debridement was of off-label nature. So as we described in Circle, we have like a donut pattern of the femtosecond laser application, which joins the lamellar cut of the smile to the side cuts of the flap cut, which is going to be created later on, so that we can entirely lift up the flap, keeping the same interface. So yeah, that is the basic thing about that.
Congratulations, Vardhaman, for that wonderful video. It was really wonderful.
Thank you.
I would just ask you whether you would like to use mitomycin in that interface, or would you, just use an alcohol-based kind of a swab and just remove those nests?
So basically, in this case, I've used mitomycin C in the interface and then put the flap back. But if there is a recurrence, definitely we also use alcohol to kill the rest of the cells if it is possible. In this case, the thing was that it was a very small confluence that we could see, and it was very easy to debride it. The main challenge in this case was access to the epithelial ingrowth to debride it more than anything else. But it is also possible you can also combine it with the alcohol as well at the same time, definitely.
Vardhaman, how do you make sure that the debridement is complete?
Ma'am, when we there are certain things that we can do. So in this case, let's say that with the experience, I don't mark it, but initially I used to mark with the pen to know what was the extent on the edge of the flap, and then debride everything. But then we have to keep on debriding till the time we don't get any cells on our spatula, basically, and then we have to make sure that we do it also on the undersurface of the flap.
Okay, wonderful.
I think Dr. Arun wants to add something. Dr. Arun?
Sure. Vardhaman, what was the vision of this patient at the end?
So the patient gained 6/9 partial vision with a small mixed astigmatism. Now I think he was plus 0.5 with minus 2.5. And now that I have seen, now this vision is about, I think, 6 months or more ago. Now when we saw him about, I think, 1.5 months ago, his vision was similar, 6/9, but his topographic appearance and the quality of vision had improved further. There is one more thing that we did for this patient now is that we have put him on a miniscleral contact lens because he was having mild ghosting in spite of that. And now he's actually with that is 6/6 absolutely, and he's doing very well.
So I have corrected a number of smile complications. I don't want to go into this topic right now because I don't believe smile is the correct direction. It's a wrong direction in the evolution of refractive surgery. Hence, there are so many U-turns that everybody is taking, right? So we'll talk about this later because it's a huge topic. The number of complications I see from smile varies. Many of them are not in literature. This is a surgery which has been described as minimalistic because doctors provided an Achilles heel of fear for LASIK. Surface refractive surgery, what I've been doing for over 28 years, is the way to go. In this patient, if I was his doctor, when you sent him back, Vardhaman, I would insist on his doctor to fix him to 2020. That's his request. So we're going to talk about this in detail. We do not want success to be a contact lens or a topography. So to me, the original surgeon, when you send him back, insists that he does a surface procedure, and 100% this patient will be down to 2020. The fact that smile can never correct its complications is one of the reasons why it's not the evolution in refractive surgery. It's what I call an entertaining sight turn.
Yeah, I think it will require a big discussion over it. So
I
think
big one
probably we don't have enough time. We don't have enough time for it right now.
Because if we start discussing, we have like 5 or 6 smile stalwarts sitting here who will, probably love to debate with you on this.
Yes, definitely. We can have a separate session about it. Yeah.
Exactly. So very, very important. We keep talking in this seminar is how topography is not success. It's the patient. If the patient did not touch 2020, excellent video, excellent job done, but this will constantly remind you 5 years from now, as I keep teaching, when we do or when we are in a wrong direction on the highway, you take many turns. That's where smile is going to be. It's very important to understand, fixing this case in 1994 when I described epithelial ingrowth, all the surfaces done, alcohol should never be used. Mitomycin was an excellent idea because guess what you use with surface surgery? To me, 90% of the success here was mitomycin. And removing the epithelial tissue is, as you explained, very, very easy. It's like a milky stuff sitting there on the underside of the flap, on the stroma, and must always still stain the edges of the corneal flap. So excellent job.
Thank you.
Thank you very much, Vardhaman.
Yeah.
So next we move on to the next surgeon, Dr. Sora Patwardhan. He is director of Nandadeep Eye Hospital, Sangli, and he's a proficient cataract and VR surgeon as well. And he regularly conducts numerous surgical teaching sessions. He has an amazing collection of videos. And Dr. Sora Patwardhan, looking forward for your video.
Thank you, Dr. Harshul, for that very kind introduction. So is it visible now?
Yes. Yes.
Okay, so I will start my video. It's a case of traumatic cataract, an interesting one. This lady, around 55-year-old, had trauma with a thorn probably around 25 years back. And for 25 years, she didn't visit any doctor because she was working fine with the other eye. Now the other eye developed cataract. So now she came with the decrease of vision in the other eye. And then when I saw this eye, I said that let's try something for this eye as well. So this is a post-traumatic, old post-trauma cataract, and I stained the anterior capsule. You can see the capsule is torn at the time of trauma. So I decided that I will open up the capsule on the side of the central calcified, or I would say fibrosed area, and could make some space there. And you can see on the side there are these. There is this nucleus, maybe partially absorbed, and looks quite similar to the shimmering ring, which we see in many post-op congenital cataracts when we do the secondary IL implantation. So I decided to very carefully do some hydrodissection and separate these remnant. I thought it is a cortex, but it was quite significantly dense also. So I carefully dissected out these pieces. I tried to enlarge the CCC from the upper side also, because there was some material which was entrapped there. So with the visco dissection, I could release this remnant material from the bag. So I was very careful because I didn't know what was the posterior capsular status. I can see a thorn prick, or you can see an iris hole over there, small hole. So it could have damaged the posterior capsule as well. So I am keeping very low settings, very low bottle height, low vacuum. Use good viscoelastic to cover the endothelium. And basically this was like a very dense chunk, little bit leathery kind of chunk. So I emulsified it with very low parameters in the anterior chamber. The bottle height, I remember, was just 50 centimeters, and so the IOP. And I nudged out the remaining piece as well. And this was the area I was little worried, because you can see the thorn has pricked in that area. So that could have been the open posterior capsule. Luckily, it was not. Now I decided that I will, dissect this out, this membrane from the posterior capsule. That reminds me of ILM peeling, which I usually do. So I decided to peel this membrane off very carefully, very gradually. And luckily, I could get it off the posterior capsule without causing tear. And this was basically the fibrosed bands which were going under the capsule till the periphery. So I released them all around. And now I decided to polish off the remaining cortex, because I didn't want any inflammation in the post-operative period. So I'm cleaning off whatever is remaining. Again, very careful about the posterior capsule, because I know there can be a prick. Hopefully it was fibrosed by this time. Important thing is not to allow the AC to be too shallow, at the same time not too deep as well, and clean out the cortex as far as possible. And of course, 3-piece IOL, I could see that the posterior capsule was nice and intact. I decided to place it in the sulcus, because the CCC was too large, and I didn't want the lens later to pop up, so that one haptic remains in the bag and one in the sulcus, and that may lead to some tilt. So I decided to place the IOL in the sulcus itself, so that the refractive stability is better on the long run. So that was the end of the surgery. So this was the end of the surgery here. So this was before and this was after. Quite happy patient, and I was quite happy to see that posterior capsule.
Thank you very much, Dr. Saurabh. That was a wonderful surgery. Dr. Gaurav, Dr.
Yes.
Sonu, would you like to come in here? And
yeah, so I think first of all, I must compliment you at the quality of the video. It was fantastic. It was very sharp, and I know that you work very hard with doing very good recording. So excellent video. And then I think the dexterity with which you made the capsular opening and kind of rotated out that those chunks of very old cataract, which obviously are very chalky and stuff, and then managing to get a 3-piece lens, which is the correct way. I think you did everything right. So frankly, I wouldn't be able to pick a fault in what you did. You did everything that I would have wanted to do. And I think let's ask Dr. Sonu if he has something to chip in there.
Yeah, Gaurav, I'd like to add on your same views. I think it was a wonderful, excellent surgery and very well managed. I think I would have reciprocated the same. I think what Arun says 2020. So I think he's done a wonderful job to let the patient have that wonderful vision. I hope the patient recovered and there was no element of myopia, because as you said that it was a long history of trauma in this patient.
Yeah, luckily the patient recovered well, because he got trauma at adult age, so there was no amblyopia. That was the lucky part.
Congratulations.
Just one comment I would like to make.
Yes, ma'am.
Fantastic surgery, Saurabh.
Yeah.
You were pretty lucky that the capsule was stable. But most of the time, what I do is when I work up these patients of traumatic cataract, I always order a preoperative UBM. I get a UBM done. The UBM helps to assess the zonular integrity as well as tell us about the posterior capsule. So that is just for some of our listeners that UBM could be useful to assess the capsular status in such cases.
Yeah.
Dr. Arun, yes.
I think excellent surgery, very nicely done. Only one thing I would do different is when you saw the plaque on the posterior capsule, I would have visco-dissected it rather than wonder what's happening behind. That's 100% way of being absolutely sure that you're getting what you want. And I love the fact that you focused on the vision. That's the biggest part I think we have to deliver today. Surgery we can teach, attitude we have to develop. So lovely surgery, I loved it, but just that step, I would have put viscoelastic below the pipe.
In fact, I tried dissecting it out, but the issue was that it was too adherent. So maybe I could have first nudged it up, made a space, and then I could have added some visco. With viscoelastic, I was a little bit unsure, because I was a little bit, afraid that the expansion may cause some opening in the posterior capsule. So of course, yeah, it could be a good idea to just try. I tried it. In fact, I edited it out because it was not successful. But I think that's a brilliant suggestion.
Saurabh, this was fantastic surgery. I just wanted to know the post-op vision of the patient.
This patient got around 20/30 vision, so which was quite good, better than what I expected.
Yes.
Or what's the remaining refractive error?
Yes, sir.
What is the refractive error remaining?
Refractive error was just 0.75 cylinder, and which was because of might be the incision, because I made the incision superiorly, so that might have caused a little bit of astigmatism in that area. I changed the IL power also in between, just to, because now I was not implanting in the back, so I changed the IL power. So that was a good decision by me. So I think fairly good vision that patient.
So does he see 20/20 with that refraction?
With 0.75 diopter, no. I think she has maybe a little bit of effects of trauma also. So might be the earlier inflammation which might have reduced her potential vision.
So the great point you're bringing across here is you went all the way and you pushed it. Now, had she seen or had this patient seen better with that cylinder, absolutely we shouldn't stop. We have to finish.
Yeah.
Super job. Excellent.
Thank you. Thank you, sir.
Very nice. Thank you very much, Dr. Saurabh.
Thank you.
Next, we have Dr. Gaurav Luthra. I think he doesn't need any introduction. He is the most sought after speaker in Indian ophthalmology. He is director of Drishti Eye Institute, Dehradun. He was the past member scientific committee member of AIOS. And he's one of the key opinion leaders in Indian ophthalmology. And he's a meticulous surgeon. I have seen his surgeries hundreds of times. He is a surgeon par excellence. And he has been inspiration of thousands of ophthalmologists around the globe. Dr. Gaurav Luthra.
Thanks, Harshul, for that introduction. You've made my job very difficult by telling that all that. So let's see. I'll try to live up to what you've said. And so I made a small change to the surgery that I'm planning to show, since we are trying to all show 2020 and six outcomes. But this is a very challenging case. The other one I was going to show was a keratoplasty where it was like a nightmare, one of those worst case scenarios. But let's see, this is a very challenging case as well. Let me just maximize it. Okay, here goes. So this patient is a one-eyed patient with almost a black cataract. Patient has been delaying surgery for almost 3 years, was advised to undergo a surgery 3 years back, and has a little bit of a leathery kind of a cataract, and we decided to go ahead with the surgery with full precautions. So I'll just try to mute this. I know that the sound troubles us. So maybe can you still hear me? I've muted the music there. Am I audible?
Yeah, audible.
Okay, perfect. So as you can see, it's a floppy iris. This patient had, we were anticipating very, very hard.
Dr. Gaurav,
and yes,
you need to share your screen.
It's not there?
Getting the input from your screen. Yeah.
I'm getting it. I'm seeing it.
You have it?
I'm getting it also.
I'm getting.
Yeah.
I'm getting.
I'm getting it also.
Even I'm getting it.
All right. So is it visible to to everybody? So I think I'll just go on.
It is. Yeah,
You
it
must
is.
stop your video.
Harshul, can you see?
Yeah, we can see it.
Okay.
Yes, yes.
All right. So I think essentially you can see that I'm struggling with the cataract. The pupil is coming down. It's a very, very hard cataract with proper lateral separation and breaking the posterior plate. At this point I was tempted to actually switch to a device which would like a iris hooks or something to do it. But you can see that at one point I was almost going to catch the iris there. But frankly, because I had made the initial 2 cracks and I was confident that once my 2 cracks are there, I will be able to complete the surgery. You can see that the pupil is, coming down quite a bit. I was using viscoat, intermittently to make sure that things remain on track. And essentially at this point now, once we are here, I noticed that the PC was literally jumping up. It was so loose, and I felt that the bag would come out with the aspiration. The cortex was very, very sticky, as you can see over there, and it was literally stuck to the posterior capsule. I had a very, very tough time trying to get it out. At this point, I used phenocaine to get a slightly better pupil size over there. It's a magical drug which saves your day. You can see that it's given me a little bit of pupil to work with, and now it's you can almost feel that the PC will come out with the aspiration over there. I'm literally having to peel it off, and I'm very scared because the capsule is totally, it's tented and it's in folds. It's a very lax bag. I want to put in a CTR right now, but I'm worried that then the cortex will not come out at all. So at some point I will have to put in a CTR. So I'm making progress while I still can. You can see I'm using a bimanual technique, holding the PC back with my infusion and still aspirating a little bit without pulling on it, and using viscoelastic to inflate the bag at several points. I tried to switch off the music, but somehow maybe, okay. So at this point, then I take a decision to put in the CTR, because now very little of the cortex remains, and it's not possible to proceed any further with the cortex removal without a CTR in place. It really adds a lot of peace of mind. Even with the CTR in place, you can see that the bag, tends to move with every small piece of cortex. So it's a very slow and steady kind of a thing. You should not be in a rush. The moment you're in a rush in these situations, you will end up with a complication. And you can see that I'm using my infusion on the left hand to actually push the PC away in the area where I'm aspirating. So, I'll just take you back a little bit over there, and you can notice that, as I get that cortex out from the other side, I will use the left hand. Yes, just see, I'm using the infusion, and the infusion is running in the area where I'm aspirating. So what it does is that it tends to push the PC away. So anywhere that you're trying to remove some cortex which is stuck to the posterior capsule, as you kind of try to tease it off, you can have your infusion on. Now, getting a lens into these bags is always challenging. I normally would do a hydroimplantation, but here is one indication where I don't use hydroimplantation. Here I like to use good visco.
Has the video stopped, Harshal?
Yeah.
Yeah, I think that his computer.
I think we have lost the connection.
Can you hear me now?
Yeah.
He's back.
Yeah, we had a park.
Yeah, we are
so
back.
For a moment, my modem went off. Yeah, I'm back now. So
Your screen is frozen, Gaurav. We can hear you, but
Lost you again. Your video is
okay.
stalled.
Could you see the last part of the
Yeah, we saw that.
video, or should I show the last part once again?
we saw. Yeah, we saw the irrigation explosion at the end after the
We saw the lens implantation.
No? Am I audible?
Yes.
Yes.
Okay. So I think I won't have to show it again because we had a power cut just like 1 minute before my a few minutes before my video. All the same, if
Okay.
am I there with you guys?
Yeah, we can hear you. So I think that was a very difficult case, very well managed by Dr.
Okay,
Gaurav.
Harshal, I'm back. I'm sorry, there was a power cut and
Yes.
it switched connections for the internet. So I was
right.
Yes.
So that was very well managed, Dr. Gaurav. Why not pupil expanded device to save from a lot of problems which can happen? Can you hear me? Hello.
Yes.
Hello.
Yes, Harshal, I'm with you. Yeah.
Yeah. So I was asking, why didn't you use any pupil expanded device in this case? It would have saved a lot of trouble.
I think Dr. Gaurav is. So I think Harshal, what Dr. Gaurav showed.
Yes.
What Dr. Gaurav showed was a very good, trick is to put that irrigation inside the capsular bag so that it inflates the whole capsular bag, and then you can use irrigation as a mechanism so as to be able to slowly dissect out whatever cortex is left behind.
Yes.
Take home message.
So I think one question which remains here: the use of pupil expanding device. Should we at the beginning go in for a pupil expanding device, or during the point where he was trying to put in phenocaine? At that point, we should have gone in and chipped in a pupil expanding device. So let us have an opinion from Dr. Arun. What is his take on this?
So I think Gaurav did an excellent job in that case, and I would not need a pupil expansion device. Here is why. Of course, you can use it. It'll make the surgery much more easier. But the fact that when you saw he was able to crack the nucleus very confidently, you saw the reflex coming through. So the job is done for cataract surgery. What I would have done different is when he was going after the cortex and the bag was flopping, you noticed the posterior part of the capsule, the central, was clear. I would have put the lens in at that point, and I would not worry about anything. With full confidence, step on my eye with the lens below me and get all my cortex and come out. So that's the only difference that I would do, is I would not let the capsule come up and down, worry, or put a CTR in. At that time, now this is very important. This central capsule was clear. The periphery was sticky cortex. I would put my lens in and not worry about anything, let the pupil come down, confidently you're going over the lens and finish the case.
I think I also would agree with Dr. Gulani. That would have been a safer way to go about it. Once you have your lens in, then you can just,
but I think that's a discussion.
You can just go after the cortex.
Somil, you'd like to add something? Unmute, please.
Yeah. Yes. My only thing is about I agree with Dr. Arun that pupil expansion device may not be necessary. It depends on surgeon to surgeon. It depends on the expertise of the surgeon and how comfortable you are. But for me, the worrisome part is that the fluttering capsule. And one way to go about it is putting the lens in. The other part is putting the CTR. But we need to remember that putting a CTR in such a situation is also difficult. It might just tear off through the capsule, and we might land up with losing the posterior capsule entirely.
I'm back, Harshul, and I
Yes.
think I was able to join in for the last few tips. We had a power cut and there's a storm coming up outside, so the internet went off for a few seconds. So I completely agree with all those points done. Now, for the pupil expansion, because we used phenocane at some point, I was able to proceed till the point that I needed the phenocane, and then it gave me that extra 2 mm of pupil. And I think it's a miraculous thing for when you're stuck in these situations without having to resort to one of the pupil expansion devices, which can have complications of their own. And yes, I, compared to some other surgeons, I do like to delay the CTR to the point where I cannot proceed or where the safety is getting compromised. So I am not in a rush to put in the CTR. I'm usually there when it's absolutely required, because otherwise sometimes you then keep struggling with the cortex. But point well taken that Arun said that the central PC was all clear and, he would have put in the lens. And yes, putting in a lens would have been good, but maybe I would have struggled a little bit with the peripheral cortex. Yes, it becomes easier to get the cortex out when the bag is kind of filled up with the lens, and it creates space as well, and fluttering of the PC would stop. But I guess there are several ways to bell the cat, and I chose one. So
yeah,
I think
that was very well managed.
One more point. I think Dr. Gaurav is very experienced. So he immediately judged whether there is a zonular problem or it's just a posterior capsular dehiscence. Because if it is a zonular problem, then I think putting the capsule, the iris retractors and checking the zonules is important. But I think he rightly judged it that it's just the capsule which is coming up and not the zonules are quite stable. So I think it shows his experience in the surgery.
You're very right.
Dr. Deepak wants to add something.
I think I must congratulate Dr. Gaurav for doing an exemplary job. I think it just shows his skill and confidence levels. There are two. One major concern for me is the way the posterior capsule is moving up and down. So I personally would have inserted the CTR a little bit earlier. It would have helped me in two ways. First would be, if at all, because of generalized zonular laxity, sometimes the fluid can get across, cause a fluid misdirection syndrome, something like that, and push the PC up a little bit. So if I insert my PC CTR a little bit earlier, it would have taken care of that part, expanded the bag, and also made the bag less floppy. So I personally would have probably thought of putting a CTR slightly early. But great job done.
No, excellent points. And I think that point about the capsule being floppy, because it's very important. If you have zonular dehiscence, you should go in with the CTR first thing, if you notice. And at one point I did think that I was having some the bag was getting kind of disconnected from the thing, and at that point it was basically the cortex. As it was coming out, the whole bag was trying to come out, but I was quick to judge that it wasn't the case and it was just a floppy capsule. Anyway, I think we've spent enough time on this. Harshal.
So thank you very much, Dr. Gaurav. Now next we have Dr. Deepak Meghur. He's the director of Meghur Eye Center in Bidar, Karnataka. He's a very skillful surgeon, and his videos are a real treat to watch for. We always look forward for Deepak's videos, that what's new is coming up, and his video quality is par excellence. Dr. Deepak.
Hi, Harshul. Am I audible now?
Yes.
Okay, I think I am presenting a case of a management of a large Descemet's membrane detachment, which is quite a nightmare to manage. The reason for presenting this case is the way that I have managed this case is slightly different from the usual recommendations that we have. So this was a case which was referred to me from my colleague. Patient has undergone surgery 3 days post-op. And the surgeon has diagnosed intraoperative Descemet's membrane detachment. He had already put in the lens, and this is how the eye looks when he presents. So this is the situation. We have a clear-cut area of demarcation here, which shows that the inferior cornea has corneal edema. That is the area of the Descemet's membrane detachment. And to complicate the issue, we also have a retained lens matter inside the eye. The patient has undergone manual SICS. And this is the OCT picture. And Harshul, I would like to just pause here for a second.
Yes, yes.
Yeah. So the OCT did show that the inferior end of the Descemet membrane was free. It was not attached to the stroma at all. It was scrolled up and it was free floating. So we have got a couple of challenges to deal with here. First, to fix the Descemet membrane and also to take care of the remaining lens matter here. And obviously, we need to understand the surgeon has used viscoelastic inside the eye during the initial maneuvering. So all these things are going to complicate the way we are going to manage and also the outcome. So let's see how it is going to be. Can you play the video?
Yeah.
So this is a part which is attached and there is an inferior part which is detached. So let us see how it is. The first thing which I plan is to first, pressurize the eye and flatten the detached membrane so that further maneuvers are not going to extend its detachment. At the same time, I'm trying to express the lens matter, the soft epinucleus by doing a passive expression here. And I need to remove some of the cortex which is there. See, the OVD is trying to pressurize and hold the DM, and I'm trying to gently aspirate out some of the cortex which is there. And unfortunately, it was just behind the lens actually. So it making my job a little bit more difficult. But when I'm irrigating, now because the visco has escaped out, I can see that the Descemet membrane is fluttering around and floating away. These arrows indicate the area where it is attached, and rest of it is all detached here. So that's where you can see the membrane is fluttering around. And this is the challenge here. Now, how do we fix this here? And then contrary to the usual way of managing, I decided to suture this inferior detachment by anchoring the Descemet membrane back. I'm using a full thickness suture here, the steno nylon. The air is pressurized, the chamber is pressurized by using air complete fill, and I'm using these full thickness nylon sutures here. And after the first suture, I just irrigate out the bubble a little bit just to see whether my suture has engaged and is encompassing the Descemet membrane, whether it is really full thickness. At this stage, I'm not seeing any free floating membrane that gives me enough confidence that my suture has indeed engaged the Descemet membrane there back. And now, again, filling the air, and I'm proceeding to put these full thickness nylon sutures. And I'm using 3 of these horizontal sutures. They are still away from my visual axis. And all the knots are eventually buried. So they're well covered. That's not an issue here. And the main wound also is sutured back. And now I'm exchanging the air with 10% SF6 gas. So I prefer to use SF6 because it's relatively shorter staying. And anyway, we have the sutures to hold the Descemet membrane back here. So I used 0.1 ml of gas, and again I'm using this concentration of 10% SF6 gas, and I'm trying to. It will be initially overfilled, and after some time, I'm just going to release a little bit so that at least 80% of the chamber is filled with this gas bubble. And then in the immediate post-operative period, obviously, we need to follow him very frequently to rule out any pressure rise. And this is how the eye is looking in the first post-operative day. The air bubble has shifted up, but the sutures in the inferior portion are holding the Descemet membrane quite well enough. So let's go and see how the OCT looks like. When we see the OCT, the areas where the sutures are there, the Descemet is sticking around, but where the sutures are not there, still the Descemet membrane is still flimsy. And 4 days post-op, this is how it is. And the cornea is cleared up a little bit and significantly, and the visual axis is clear. And the OCT, although the area where the sutures are there, it's still holding good, but the other areas we can still see some amount of areas of detachment. And the sutures are stay put here, and let's see what happens after 1 month. And this is 1 month post-operative picture. And luckily for me, the cornea is totally cleared off and there's no inflammation. This is how the visual axis, the OCT is in the visual axis. This is the area of scarring where the sutures have passed. But the patient did very well, and the sutures were released after 6 weeks. Patient had a residual refraction of -1.5, 90 degrees. That was predominantly the stigmatism. And at 2 months, we did give him correction, and the patient ended up very happy. So thank you for your, thank you for the opportunity, Harshul, and thank you, Rajasthan Ophthalmic Society and Maharashtra Ophthalmic Society.
Thank you very much, Dr. Deepak, for showing that wonderful case. So I'd like to chip in here, Dr. Vardhaman. Vardhaman, are you there?
Yeah, I'm there.
Yeah. So, yeah, and Samresh, please.
Right. So,
yes.
Of course, as I think as usual, Dr. Deepak's surgeries are a sight to watch, and they were beautifully documented and wonderfully managed. It was definitely a very difficult case to manage, especially Descemet's membrane detachment in SSCS when we have a very big incision with intraoperative complications is not easy thing to manage, and the full thickness sutures that Dr. Deepak has used has also been described in hydrops. Actually, when there is a Descemet's tear in hydrops in advanced keratoconus, along with the SF6 or C3F8 gas, compression sutures, full thickness compression sutures have been described in the past. So I think in this case, he has applied those principles very well. I would like to actually know what was the age of this patient.
The patient was 60 years old.
60 years old. Okay, because usually what we have also seen with Descemet's detachments and the corneal behavior, younger the patient, definitely the outcomes are better. In this case, I think compared to what we expected, looking at the preoperative, including your intraoperative video, the outcomes were far better than what we expected it to have. So I think everything was done in the best interest of the patient, and wonderful innovation in all the steps. Yeah.
No, I think the reason why I'm presenting this case is the standard protocol which we follow for Descemet's membrane detachment is using just the gas. But I have had experiences for the last maybe few years where I have used only gas. Whenever we have an inferior Descemet's membrane detachment, gas alone doesn't really support the DM, because I have had multiple instances where the detachment detaches as soon as the gas bubble shrinks. So there is some time frame for the endothelial pump to kick in because in cataract surgery, I think the OVD which is used gets in the interface between the endothelium and the stroma, and that interferes the functioning of the endothelial pump to kick in. So many of the times in inferior detachments are extremely challenging because as soon as the expansile gas shrinks, the detachment just comes back again. So I have instances where I have to intervene about 3 to 4 times again. So this suturing is actually an old technique. It was invented before even the gas came in. So this was about, say, 30 years back. We were using something like this. But my philosophy is whenever we have an inferior detachments, these are massive inferior detachments which don't have, it's not a stromal detachment. It's a complete through and through detachment. I think if we use the full thickness sutures in your first go, that will serve us better than using just expansile gas.
I think true, because it is going to also anchor the endothelium, anchor the Descemet's and the endothelial complex.
We are giving a mechanical apposition rather than a temporary gas apposition.
Correct, absolutely.
Somil wants to add something here.
Very good video. Just wanted to ask about what was the refractive error after the entire thing was removed.
Once the sutures were removed and we refracted after the sutures were removed, 1 month post the sutures removed, she was having minus 1.5 90 degrees, and I attribute to the large SICS incision which the patient was having.
Very.
Dr. Sandeep,
can I make a comment?
Dr. Deepak?
Yeah, sure.
Can't we augment this procedure, suturing, full thickness suturing, as well as gas tamponade?
Yeah, I did so, sir. Actually, I did so. Actually, I used 10% SF6 gas as well. SF6 gas stays there for maybe 3-4 days, 5 days maximum. But we require the long-term support for this. That's the reason why I think in these large inferior detachments, suturing would be a better option.
Just one comment. Dr. Deepak, there was a very well-managed case, I must say, and a fantastic video. Just since you took the sutures, I believe there was no need for positioning the patient, right? Normally, just inject gas, you would want to position the patient. So
absolutely, I agree with that. And although I still advise the patient to maintain a position, but it's not practical to maintain position for long durations of time here. But that helps.
So one point I'd like to make, Doctor, excellent surgery, very good surgery. But I think for the listeners here, because all the panel here are such experienced surgeons, that we should not give them options. We should give them what would everybody do. Have to do it this way and why. So I loved about your surgery. The one part in particular was the way you took the stitches, because you kept it astigmatically neutral by taking it long and taking it not too tight. That I think is $1 million portion of the video. The rest doesn't matter. What I would have done. In this patient, first of all, you did a great job with the incision. You could see it was self-sealing. So there was no need to take a stitch in that later because you did not distort much of it. 2, I absolutely agree when there's an inferior detachment, many of these, but I don't believe in SF6. I just put the whole air bubble and I do an inferior iridectomy. Now, for some surgeons, because visibility there was poor, we can counter that discussion, but in your case, I would have done an inferior iridectomy, full chamber, anterior chamber, full with just air, and put it there. I have never had to take a stitch, but I love the point that you said. It's always an anchor point. Maybe the patient was traveling or couldn't come back to you soon. One stitch in that area would have been perfect, but I love the fact that you were so intent of not inducing astigmatism. I love that part of this video. Excellent job.
Thank you. Thank you so much.
Thank you very much, Dr. Deepak. Now we move on to our next speaker, Dr. Samresh Srivastav, who is from Jaipur. He is director of Raghudeep Eye Hospital in Jaipur. A wonderful surgeon. And I must say that he is one of the Indian ophthalmologists who has won numerous international awards for his innovations. And we are very proud of Samresh, that he's from Jaipur. Samresh with his video.
Thank you, Harshbhai. Can you hear me? Am I? All right.
Yes, yes.
All right. So it's a great honor to present in front of Dr. Gulani, who have been inspired for so many years. We also share our birthdays, if he doesn't know. So there's a common point there. So discussing complications. So this is a patient who's had a one-eye posterior polar cataract surgery done and comes to us for the second eye surgery. Now I've been grading posterior polar cataracts for quite a few years now, and there's a very clear indication on whether a cataract is a polar or a pseudopolar. But we went ahead and followed all the norms of a polar cataract, although this did appear to be a pseudopolar cataract to me on a slit lamp using lower parameters, and we were able to debulk. This was a femto-assisted surgery. And what we were left with was an epinuclear bowl. Using again low parameters and control technique of bimanual irrigation and aspiration, we took out the one needs to do an exchange of viscoelastic before removing an instrument, because the last thing you want is a shallowing sudden of the anterior chamber, because the capsule can rupture. And went ahead and did an IOL implantation. Like I said, this was a restore. It was a multifocal lens. Although the patient was counseled that in the worst case situation of a dehiscence, we will not be able to put a multifocal lens. But because the posterior capsule was absolutely intact, there was really no problem. The lens centered well, 360 degrees cover as would be expected with a femto-assisted rexis. And my standard for removing viscoelastic is a bimanual IA, where my irrigation goes behind, pulls out of the cohesive. And notice what happens at some point in time, despite the aspiration in front of the lens and the irrigation behind on a very controlled manner, you can still see a large area of a capsular dehiscence. Now, this is a patient that has a multifocal lens inside the eye. So I decided to see what happens if I hydrate the incisions. So here I'm hydrating the side port incisions and then trying to recenter the lens, hoping against hope that nothing happens and then this should be the end of the surgery. But since the lens didn't recenter, I tried to use triamcinolone, and it's easy to make out right now. There's a huge blob of vitreous which has prolapsed from that PCR and is now lying at the size of the incision. Now, this is a very, very big dilemma situation, because really it's very difficult to understand how to go ahead. Should I go ahead and do a limbal vitrectomy? Should I explant the IOL, because this is a multifocal IOL inside the eye? For the last few years, we've shifted our paths from doing limbal vitrectomy to pars plana vitrectomy. So I decided that after I fill in dispersive viscoelastic viscoat in this eye, I made a pars plana entry. So just to show you that the irrigation is inside the anterior chamber over here, but my vitrector, 23 gauge vitrector, goes through pars plana 3 millimeters from the limbus, and I'm attacking the vitreous from behind the posterior capsule. And notice how this entire blob of vitreous gets dragged back. If I were to do a limbal vitrectomy, I would have to do an anterior tractional force, but because I approached this vitreous from the pars plana route, I was using highest cut rate possible, a moderate bottle height, say about a 50-50 bottle height, and a vacuum about 250-300 to be able to pull out all this vitreous back into its natural compartment, which is the posterior compartment. One has to be slow and has to move beyond the area of the PCR margin to be able to clear a good amount of vitreous. Once the anterior little bit of vitreous was bullet on from the body of the rest of the vitreous, the limited small vitreous bead that was lying at the irrigation site was handled by a bimanual vitrectomy using the same vitrector. Notice over here, this is the entry for using a trocar cannula system. One can also use an MVR system for using the same vitrectomy. But against the principles of the limbal vitrectomy, is to put the irrigation in anteriorly and the aspiration far behind to be able to finish this maneuver. And once this was done, we were able to recenter the lens's place. I don't know, the video seems to have stopped. We were able to recenter the lens back into its place and get back to a patient with a restore in his which had a restore implanted in the eye. Just see if I can just try it out for the very last time. See if I can show you the very last post-operative picture of the patient. And this is how the patient looks on the post-op day. This was post-op day 7, and this is how the patient looks at 3 months post-op. So we were able to achieve a well-centered multifocal lens inside the eye, inside the capsular bag, simply because we decided to tackle the complication through a different approach, through a pass plan approach rather than a limbal approach, which would have probably made the capsular bag a little less likely place of implantation, and we might have to expand the lens again. Thanks.
So thank you very much, Samresh, for showing a beautiful teaching video. I think you showed everything what should be done if we land up in a problem like this. If we have a PCR. So I think you showed very nicely that we should always stain the vitreous with triepsilon, because without staining we can't make out that what is the extent of the problem of vitreous which is there. And going through pass plan route is of course a better way if you want to take off all the vitreous nicely. So I'd like to add in here Dr. Deepak, Dr. Janin, for their views. And any questions from Samresh?
Samresh, I think you did a wonderful job. Congratulations. I think you premium case and unexpectedly the PC tear happens. What do you think is the reason why the PC tear happened actually? Could you figure it out later?
So my feeling is that all these patients with the posterior polar cataract have an inherently weak capsule, because there have been times where I've put the IOL in the bag and I'm hydrating the incisions, and because the pressure inside the eye increases, the entire posterior capsule bursts open. So in a posterior polar cataract, the surgery is not over unless it's over actually, and one cannot plan a coffee after the surgery because you never know how long it's going to last. And I think that's a big message that I've learned after burning my fingers many times. You know, it's a posterior polar cataracts can give you complications right till the very end.
Yeah, I think you can't be complacent at any stage. Dr. Jenny, would like to add something?
Fresh, beautiful surgery, and of course, pars plana vitrectomy is the way to go. So, 2 questions here. One is there are papers which are published on pars plicatum vitrectomy and versus the pars plana vitrectomy. So, how would you wish to put both of them in their own perspectives, and which one for an anterior segment surgeon? I'm looking at it purely from a person who's running, say, a neophyte surgeon who wants to take to the process. So how does he go about with it? And the second one is definitely trocar cannula is definitely the recommended way, because your retinal tears will be lesser and you have the way to guide a vitrectomy. But just in case you don't have it, how about a bare sclera for people who aren't as equipped, to just as a trying method for the...
I think, Dr. Janet, they are very valid questions, and I think for me, for a vitrectomy, as a cataract surgeon, I think pars plana is the better approach, because you want to be as far away as possible from the anatomical structures, the bag and the lens substance, because you don't know where the anatomy is. So I would go pars plana. 3 millimeters is where I would enter. And one understands that this is a situation of compromise. So at the end of the surgery, you have to have a retinal colleague look at it in that area and make sure there's no detachment, or do a prophylactic laser barrage maybe at a month period. So it's a compromise, but in a compromise, you need to give the best outcome to the patient. So for me, for vitrectomy, pars plana is the right place. As it comes to a trocar, actually, truly speaking, I've shifted from a trocar cannula system now to an MVR-based system, because the trocar, especially the ones that we are not used to, give a lot of, you need a lot of force actually to get it inside the eye. So if I'm in doubt if my trocars are not that sharp, I open up the conjunctiva, I use a straight MVR and make a direct entry. And at the end of the surgery, I just suture off that incision. So you really don't need a trocar cannula system. You can do ahead with a straight MVR knife or a bent MVR that you would use for a side port incision. Works beautifully well. The idea is to clear off the vitreous and maintain the compartmentalization. And like Dr. Gulani has brought about, you've committed to the patient that you want to put a lens, the right lens, to give the right vision in the capsular bag, and that's your purpose. And you will fulfill your purpose as a cataract surgeon.
Another question.
Dr. Rajkumar Sharma wants to.
Just one more question, Harshal. Do you plan where you want to make an entry for your pars plana? Because usually you say the 3, 6, 9, 12 should be avoided, and where the vitreous is and where the rent is. So do you plan your shift in it, or do you just go to that one superior temporal area?
Temporally, I plan an infrared. I mean, I plan it on the right hand side because I normally would like to use a vitrector with my right hand. Gives me more dexterity that way. But I avoid the 3, 6, and 9 o'clock positions, and I make it at a slightly more angulated position so that I can approach more comfortably, more physiologically.
So we have Dr. Rajkumar Sharma, who is a renowned vitreoretinal surgeon, and he definitely wants to add here. Yes.
Thank you. As far as Dr. Janin's question is concerned, whether to go through pars pliccata or pars plana, I think from the sclera you cannot differentiate. It's just a matter of half millimeter. Just behind the pars pliccata is the pars plana. So generally we go around 3 to 3.5 millimeter behind the limbus, especially in a phakic or pseudophakic case, or where you remove cataract or where you are planning to remove the cataract. Secondly, as per Samresh was saying that trocar cannula system may be difficult. It depends on the rigidity of the eye or the intraocular pressure of the eye. If you fill the eye well or the antechamber well, trocar cannula, new trocar cannula may be as sharp as any MVR blade. So that doesn't matter. But the question to Samresh is, what was the gauge you used and what was the cut rate?
So this was done on a Centurion Vision system, and so I'm using a 23 gauge for my routine vitrectomy, and the machine gives me about 3,500 cut rates. So that I use the maximum cut rate.
That's reasonably safe, and 23 gauge is as good as 25 gauge. Maybe many people are doing exclusively 25 gauge, but 23 gauge is also as good. And I think you did the right job. Cut rate should be the maximum possible, and suction should be as low as possible, as low as you can manage, because when you are going in the periphery and near the vitreous base, especially when you are in anteriorly and if you are going peripherally, so that means you are very close to vitreous base, where the retina is firmly adherent to the vitreous base. And if you pull on the vitreous base, there are very high chances of creating a iatrogenic break or multiple breaks in that area.
Absolutely.
Yeah.
It is always better to take a look after you have completed the surgery. You must take a look with indirect ophthalmoscope. That would be better. Thank you, Harshal.
Yeah. Dr. Gaurav, what is your choice, like limbal route or pars plana route?
What are you asking? What choice between?
Between like
pars plana or so see, I have tried both the things. I've tried the trocar, and now see, because you don't have to remove the conjunctiva, and Samresh did mention that it's sometimes tough to get the trocar in, and it's requires more force and all. But off late, quality trocars and cannulas are available at a pretty reasonable price. In fact, I picked up one from AIOS this time from Money. They're making these disposable trocar systems, which are not very expensive, and they come 3 in a pack. They are very high quality, just like the Money blades and or whatever. I have no financial interest, but so it works really well. And off late, I would prefer to go, and the Centurion system with the 23 gauge is wonderfully well. So frankly, this is how I would do it today. But yes, if I had no access to a trocar, I would not hesitate to make a quick conjunctival this thing and go in with the MVR. MVR is my favorite for that as well, and that works equally well. And one suture is not going to hurt the patient.
Okay, thank you. Dr. Arun, yes?
Can I make a point here?
Sorry, go ahead.
Yes.
Dr. Samresh, that was a very well managed case. Just when I was seeing you operate, even when you were doing vitrectomy, your anterior chamber was pretty stable. So yes. I was curious to know what were your infusion parameters, because many a time what happens is when you're doing vitrectomy, pars plana, and you're giving infusion from the anterior chamber, your anterior chamber can deepen. But I saw your anterior chamber was pretty stable. So what were your parameters?
So I was using a very low, so the Centurion is an active fluidic system. So I was using an IOP of maybe 25 or 30, which translates to a bottle height of 40. So the idea was not to fill up the anterior chamber, but just to keep it right there so that I could clear off that area of vitreous which was disturbing me. So I kept my bottle height, how would you say, to a lower side so that I would not cause a lot of turbulence and deepen it suddenly, because sudden deepening can also cause the PC to sort of give way. That's all.
Right. Thank you.
Dr. Arun.
So, Samresh, fantastic. And here's the highlight of your video. Surgery obviously was excellent, but the highlight to me was you did not give up on giving the patient multifocal vision. That's the attitude of a surgeon. You don't give up. I loved it. Two, I don't think, again, this is again the way I'm going to speak, just because we want to be very clear to the guys who are listening. They're not maybe as fantastic surgeons as you. We want to make sure there are no, I don't like options. We give a plan. You said something, you used a different approach. You didn't use a different approach, you used the correct approach. Vitrectomy from posterior is the only way to do it. Everything else is wrong. That's why you worked well. 3, there was no need to use a femto laser in this case. 4, there was no need for you to go behind the lens and keep removing that. There was no cortex there. So that's my take. Again, constructive criticism, excellent surgery, but those two things were not needed for this case. Beautiful job. Love the attitude that you took him to multifocal.
Thank you. Thank you.
Thank you very much, Dr. Samresh. So next we have our star speaker of today's evening, Dr. Arun Gulani, and it's my pleasure to introduce him. He's a world-renowned eye surgeon and the director of world-famous Gulani Vision Institute in Jacksonville, Florida, USA. And Dr. Gulani, fondly known by colleagues as Da Vinci of eye surgery for his artistic surgical skills, and man of vision for his relentless pursuit of vision beyond 2020. And he's also known as Dr. GQ for his immaculate dress sense and fashion, which we all have seen. So originally he's from Mumbai, India, and he's listed in Forbes among top 10 laser vision surgeons in the USA as one of the most famous eye surgeons in the world with a global clientele. It's our pleasure to have Dr. Gulani with us today. Dr. Gulani.
Well, first, thank you so much, Harshul, for the invite. I think this is a wonderful webinar, especially because all of you, your surgical skills are so fantastic that we can take it straight to what I call attitude, straight from here, for the listeners' benefits. So as I start sharing the screen right now.
Yes.
Are you able to see?
No.
Not yet.
Here we go.
Yeah.
Perfect. Can you see now?
Yes.
Okay. So I will just change tracks a little bit, again, because like I said, the privilege of speaking on such a podium is all of you are fantastic surgeons. I'm going to keep on hammering the one thing that I want, which is attitude. First of all, I don't believe in calling any case a nightmare because that paralyzes the surgeon and decreases the goals for the patient. So we stay away from the word, look at every situation, break it down into a dwarf and then just break its ribs, give it a fantastic outcome. That should be the goal here. So I'd like to acknowledge my co-authors. Now, what is the nightmare? When people, these titles that are being used, nightmare, it could be anatomical, which is the easiest to fix because it's a surgical skill. Refractive, which could be difficult, and psychological. So any nightmare, if you have to describe, has to fall into these categories. There's nothing else. Psychological, further, I break it into patient and surgeon. Sometimes the surgeon reaction, for example, Samaresh's video was excellent for the main reason that not only did he show the calm and poise in handling a vitreous in a multifocal lens, what I loved is he did not back out of giving the patient the vision he promised. It's psychological. I don't believe any case is a nightmare at all. What I like to teach is look beyond the cones. So this is a very important statement, actually. Myself and Hurley Haywood, who's a legend in Porsche racing, we wrote an article where we said, look beyond the cones. Cones in his case are, those orange cones on the street? They make your car go left, right, you go zigzag. It makes you turn and makes you change your plans. And cones in our cases, I met Ron said, cones meaning look beyond 2020. So the concept of analogy here for nightmares is look beyond your potholes. Stop worrying about the street being on a mountain and it's such a narrow street and there are 2 trucks coming against you and your car doesn't have brakes. Don't worry about all that. Focus completely on the vision, on being on top of that mountain and the passenger you carried, your patient, had a phenomenal journey and an outcome, and the destination was correct. So look beyond the cones. Do not worry about the cataract being subluxated, white, traumatic. You want 20/20, relentless. Focus on the destination, enjoy the ride, enjoy. I'll show you these things because it's very important to me. If you see any of my surgical videos or anything I do, the patient's face is in it. The reason I do that is very important. In fact, it's the most accountable way of showing your surgery. Otherwise, what's the point showing surgery if the patient cannot be shown smiling with you during surgery, next day post-op, and flying away saying you're amazing? So to me, it's very important, show the patients. So, and then celebrate when you arrive. Let the patient be there with you. Let them hug you. It's a great feedback to you that it was worth doing. What Vardhaman did, what Samarish did, what Deepak did, all these doctors who showed these cases, the feedback is the patient's seeing amazing. So for those of you who may not get through, I have thousands of videos on these, but I'm trying to put it down into the 8 minutes. These are the places you can go. We're building up for you, keeping videos ready. So don't panic. I'm basically here today so you can grill me with questions. So let's start with the case here. So I can share with you what a nightmare is usually. And majority of, like I said, the anatomical nightmares that are constantly shown, lenses being hanged and white cataracts being done, are the easiest to do. They should not take more than 6 minutes. Otherwise, there's something going wrong. That's my protocol. Now, cases like these, this is a nightmare because the lawsuit, this patient is referred to me, had keratoconus. His doctor did a beautiful cataract surgery, but ended up with hyperopia, high keratometry, 49, central corneal scar, anterior corneal scars, a premium lens in place, and he further opened the PC. So remember again, this is keratoconus, hyperopic endpoint, which is bad because he's now presbyopic and cannot see distance, and is the pilot. High keratometry, central scar, premium lens, open PC. What would you do?
So yeah, pausing for the discussion.
Not discussion, just even one person.
Okay. Dr. Sonu, Dr. Gaurav, you can join here.
Just 10 seconds.
Yeah.
What's the refractive error?
Refractive error here is +2, -1. And vision is 2200. It improves to 2040 with that refraction.
So maybe something on the surface we can do?
Remember again, what can you do on the surface? It's hyperopic, I said, and the Ks are 49. He's already steep, and there's a central scar. Remember again, I'm just pushing here attitude. We do not want anything less than 20/20.
Maybe a toric ICL?
Why?
But hyperopia, yes.
Exactly. So no. Because you're leaving the central scar, you're leaving the high Ks, his night vision is poor, correct? Toric ICL doesn't help you for all those three things. So, let's go ahead. Now, this patient is fuming against his doctor. He's been flown in, everything. Here's my concept. I want him to see 20/20, but to do that, my endpoint game here is I want myopic surface laser surgery, which will correct my scar, decrease my keratometry. Remember, he's over 60. He's a cataract patient. His keratoconus now is stable. I've been monitoring him. His doctor has sent me his notes. So I want the scar corrected. I want the keratometry decrease, and I want emetropia. For that final action, I need myopic laser vision surgery. Here's my dilemma. How do I get myopia when he's hyperopic? So when I sit with the patient like this, I actually make them my teammate. I say, listen, my issue here is how do I make you myopic? I need to think. And my fellows are around me. Now remember, I haven't taught surgery. I haven't going to show my skills here of removing his lens, playing with vitreous, because it will take away my 20/20. Now, here's the decision I make. He's a deep chamber keratoconus, so I put in a piggyback lens, make him myopic. All right, remember his capsule was open. Don't want to mess with anything that takes away 20/20. Surgical acrobatics without 20/20, waste of time. So I made him myopic. Now I tell these patients, I'm taking you to Paris, but first we'll have to go to Iceland. I have to go to Iceland first. There you need to be confident that you're going to take off and land both times safely, because the patient still wants to go to Paris 20/20. So make them myopic with a piggyback lens, 4-minute surgery, same incision, give him a month of refraction, re-refraction, 6 weeks, come back and do surface laser surgery. He's 2015, 1.5. He got his pilot's license. What does he remember? 4-minute surgery, 6-minute surgery, topical over a span of 6 weeks. We are done. Are we okay here? Attitude. Surgery, anyone can do. Always, this is an article coming out in Ophthalmology Times right now this month. I've said, show me the patients. Everybody remembers Jerry Maguire, show me the money. Show me the patient. If a surgeon cannot show you the patient, walk away. Don't want to see the surgery. Clear system is very important for us all. It's about 40 different techniques that we all know. I call that cooking, like baking, sauteing, frying, grilling. You must know all that, and you do. How to work on it are like a master chef, very important. So it's to blur your boundaries. There's no such thing as a cataract refractive corneal surgeon. Everybody's a vision surgeon. And do not, please do this. Repeatedly, I keep saying this. Most surgeons are consumed with what lens they're using, how they call the laser robotic. Completely wrong. Medically wrong, patient-wise wrong, and you're also hurting your community of ophthalmologists. Think for a minute. If you constantly say ingredient made you premium, you're losing the fact that you're the master chef. And the patient goes home thinking they got 20/20 because of the special lens that their husband paid for. And if they don't see, the complaint is, despite that expensive lens, this idiot doctor couldn't fix me. How fair is that? Completely wrong. Calling cataract surgery robotic makes it a complete joke because now patients are looking for the robotic cataract, not for the surgeon differentiation, and they start shopping for cost. You see where I'm going here? Do not give credit to technology. It's just an ingredient. You are the one who has to plan. Everybody is a candidate. We have all these technologies. How to use them to our maximum. Very important here, please. I'm going to share with you, these are some of the most extreme complex cases that fly to me, but I want to repeatedly share with you, especially you guys who are wonderful surgeons, you have to focus on the patient experience. And like Samresh and Vardhaman showed, you're calm and poised as you're doing it. So here's a patient who's had multiple surgeries in Abu Dhabi, sent to me with intacts in his eye, extreme keratoconus, multiple subluxations. But I want you to hear. Very important, please. How does the patient feel in your hands? Even if you have all these surgeons always watching, and watch this. This is the next day he comes on his motorbike he rents because he came from Abu Dhabi, and I'm letting him take me for a ride. My confidence and his love. Important. Please remember these pictures. I want you to be addicted to your patient's outcomes. Next, the ambiance you create. Again, patients coming out after multiple complexities sent from Arizona. Here she's being fixed, but look at her reaction. Very important.
Hi.
She had a multiple surgery. Remember, she's under trauma. Important. Whether you're doing laser correction surgery on patients who had multiple complications, same reaction. For time, I'll just keep going faster. Now, here's the patient again. My resistance to do easy things like transplants. This is a patient. He's a construction worker, big burly guy. He lifts a lot of weights, the paints on big heights, everything. Cornea with count finger vision, central scarring, 89 keratometry, 200 microns thickness. Remember, I don't care for topography. I'm just showing it to you because we discussed it that way. My point here is I want this young man to be strong in his eye and see without glasses. That's my focus. Unless you show me a full knife into someone's eyeball, I'm not going to believe if they say he's not 20/20. I want reasons. So that's the attitude. So this case was a challenge for me because even with his 200 cornea, I was able to put my intact ring in place and bring him down to 60 keratometry and clear the center. He's a tough guy. He went home, he rubbed his eye vigorously, and the intact came out. My first ever, the ring in a 200 micron cornea, it came out from the roof. What do? I don't panic. I still want him to be what I want him to be. So I moved the ring to the upper channel, stabilized that, and I stitched the lower channel, just impromptu, because all I want is compression. All I want is compression, decreasing case, and astigmatism correction. Now he's straight down to 20/30 minus. And again, the only way of showing success is the patient, not a graph. So here's a quick video. I'll just go through very fast. That's the roof that came through as he tore it with the ring. What I do is I just move the ring out. You see that? And I put it in the upper channel, which I created manually because these are very difficult cases. Lasers cannot do this. And then I go and I stitch the area like Dr. Deepak did. Again, careful about how you do it. Very important compressions. Sorry. Very important to show the compressions. But most important is this. This is the next day after surgery. I want you to get addicted to these things. Now, here's the case where, very rare cases when I use the femto laser. Again, remember, please, I'm speaking a little more hard on these things because these technologies are not needed. We all know femtolasers don't improve vision. Only places 9 years ago when it came out first, even before FDA, I wrote a whole supplement on this, on which cases it's useful for. Here's a young man with both his anterior posterior capsules stuck with absorbed cataract, trauma, and 6 vitrectomy retinal surgeries. There's no vitreous in the back. What do I want? 2020. So same thing again, attitude. I go in with the femto, cannot get a proper exit, makes it even more difficult.
Resulting in a complicated and partially absorbed patient's vision outcome, and presently applied the femtosecond laser capsules carry a situation of. So
now I have an even difficult situation. There are tags in the capsule and it's stuck down to each other. But what I want to share here again is attitude. Attitude. I want 2020. There's no way out. And remember, he has no vitreous.
The air bubble now within my edge.
So I find the edge manually. And this is Dr. Deepak, or I think another doctor has shown a fibrotic area. That's where I use the Viscor, and you can imagine it's stuck down in many places, but it gives you a balloon factor to go across. And you get a rexus. I notice the posterior capsule is deficient, so I do a posterior capsulorhexis.
So I must make a post-tensive fibrosis.
Pick a lens with the correct dioptric change for now being a posterior fixation.
More to the side in the eye, and feel.
Put it in between the leaves.
Using
I use a ritual sealant because this patient's traveling just to make sure I don't want to stitch again, cannot induce a stigmatism after all this work.
And you see here, this patient,
next day 2025 uncorrected. Very important, please. Now let's go backwards in a patient to me who was sent as a nightmare. This patient had 12 procedures with keratoconus, PDKs, PRKs, LASIK, Intacs, ICL, cross-linkings, everything. It doesn't matter. I always start refracting these patients. And if you can see, there's a cataract. So now my biggest goal here is I'm going to Paris, which is doing his cataract to 2020, but I have to go through Iceland, meaning I have to make his cornea measurable and intelligent. The first thing I do is I never say your surgeon did something wrong. I go, okay, here you are. Let's work on this concept. So at first I'm removing his ICL. Then I stabilize him. Sorry, first I go and I remove his ICL and his cataract and I leave him aphakic. Because this cornea, I don't trust with the measurement. I measure him refraction day 1 and week 1. Then I take him to a toric lens implantation. That should be the level of confidence. Here he is again, quick to go through the videos.
Has undergone multiple refractive procedures.
I'll go through fast so you can.
Implant, laser PRK, cross-linking, Intacs, cataract. Given that I could aphakia, and then see. So here I am, removing
just moving his ICL to bring it out completely.
ICL, and my technique
again, remember, I do not want to take a stitch. I don't want to take a stitch. I do not want anything less than 2020. It's the attitude. Surgery just happens.
Here we see the phakic implant
Surgery just happens. Just the full ICL completely out. Then if you see, I'm doing my manual surgery here.
I leave behind
some cortex in the bag and make it easy. Come back later because now I'm keeping him aphakic to measure him. There's nothing else that's improper in his measurement.
And I'm
Dr. Arun, if you can mute the audio from video.
Okay. All right.
Yeah. Just mute the audio from video. Yeah.
Just 1 second. I just want to make sure. Here we are.
And this is your end.
All right, you okay now?
Yeah, perfect.
Can you hear me?
Yeah.
Yes. So what I'm doing now is, if you can see,
and this is the special sealant I use.
What I'm doing now is I'm actually sharing with him what I've done. We are sitting in Iceland. He has no vision. He's aphakic. But he has to have confidence to follow you for the rest of the journey. You have to be confident now that you're hitting it perfect out of the ballpark because you cannot make a mistake now. You've carried him. He's been with you. That's the attitude part. That's the residual cortex that I left behind. I just pull it out with just a syringe. Then I go in and I'm confidently putting a toric lens in his eye and we take him straight to 20/20 minus. For him, imagine 13th surgery that brings him to 20/20. Very important. So that's his sequence, if you see. See the vision improving right there. And every time you must show the patient. Was the patient comfortable? Was he enjoying his scene? How does he feel? Very important. Now let's take you forward to my case. This was a backward case I did because I call this GPS. GPS is now known as Gulani planning system in iWorld. I have written articles on it. GPS to me means you can't just do 1-2 surgeries without thinking. There has to be a logic. You cannot get into the car, start driving. You got to plan the destination, then take your turns in that direction. So here is a patient with 9 surgical complications after a hexagonal keratotomy. You can see her keratometry here is in the 80s. Astigmatism is 23.5. And she has cataracts, Fuchs dystrophy. What would you do? 10 seconds. Cataracts, ectasia, Fuchs dystrophy, high keratometry in the 80s, astigmatism 23.5, cataract, post-hexagonal keratotomy. What would you do? So again, my aim here is cataract surgery, but I will not enter the eye until I can measure the cornea accurately. So to do the cornea accurately, I'm struggling. Very easy to do a 22-minute transplant. That's not what our plan should be. We're taking away from accuracy. So I'm deciding I need something. See how I think. I do not talk technology ever. I like to think of how I want that vision to be, and then how am I going back to my kitchen, picking up my ingredients to come and apply it. Again, this patient, I staged it because first I want the cornea to be measurable. So I decide that one surgery among 40 surgeries that will take care of his keratometry, stabilize his hexagonal keratotomy, decrease his keratometry and astigmatism directionally, and make his cornea measurable and stable is intact surgery. So I proceed with intact, and I get his astigmatism down from 23.5 to 1.4. Again, it doesn't matter how high the astigmatism was. I did not know I would get all of it. I aimed for everything. I don't care how tall the opponent is. I know where to hit. The knee, the solar plexus, and the jugular. You'll get it. So that's the attitude you have to have. The fact that I landed at 1.4 is beautiful. Now I have a measurable cornea. I wait 3 months. Now I'm confidently proceeding with a toric lens in this patient. Here's the video again. I put it on mute. So this is all the 9 complications she has. I'm going inside the eye. This is the astigmatism, 23.5. I'm putting an intact ring again here. Stabilizing, it's very difficult here because I have to go around the hex K. If I make one mistake, it goes through the hex K into the eye. This is resistance guided technique I use, so I never cut on the cornea, ever. No blades on cornea. Now that I got this, I had never used cross-linking at the same time. That's a whole different discussion. I call it linking without thinking. In this case, I'm doing it because I loved my reflex. So I cross-linked a stat. I call cross-linking trapping what we want. You're trapping it. Now, because I've got the intact, and I call this titratable technique, where the patient starts seeing under my microscope, and my reflex is the perfect circle if you see in the center. I'm straight away cross-linking her right now. We are done. Now I wait 3 months. I've changed her cornea. Now she comes dressed up. I love it. I love my patient dressing up like this. After 60 years, you could see her face again. Very important. Now I'm planning my cataract surgery. I'm going to keep my capsular rexus small, so I'm going manual. Laser cannot plan through all this. And I'm keeping the diaphragm small, and I'm going to avoid my reflections and improper visualization. So I'm staining here, do my rexus small, go inside, do my cataract. These techniques, when I do for RK or refractive, I keep my phaco probe in one place. I don't move, so you don't distort the incision. Again, remember, I'm focused on not taking a stitch. I don't want a stitch. And there it is, toric lens in the eye, a Richard sealant, given her scenario. Here she is. And also she had thyroid exophthalmos, I forgot to say, among the 9 things. And here she is completely glasses free. She became a nurse to help other people around her life. So how much time do you have, Harsha?
Yeah, do you have any more?
How much time do we have? I have tons of stuff, but I wanted to go through the thought process and then stop because I would love questions. I have tons of these stuff. But questions.
So I think let's get in all the speakers here so that we can have some good discussion. So those were amazing cases you showed, Dr. Arun, and a lot of thought process was involved. Rightly said that we don't have to be dependent on technology. We need to use our thought process and our common sense to achieve the results as you have achieved in these cases. So if we can stop the sharing, then we can get all the panelists for discussion. Yes.
A quick question from my side, Dr. Arun. So do you think in the last case that you showed, does that the concept of pinhole pupilloplasty would really work when you have just the center of the pupil, coinciding with that, the cornea, and the whole astigmatic component is being taken care of? Do you think that idea could work there?
Absolutely. So that's an excellent technique that Amar Agarwal has been teaching. Here is where I a little bit differ on these concepts, Sonu. That's Sonu, right?
Yeah.
Yes.
Very important. Very important. Are you fixing the problem? Why not fix the problem? If you fail, I'm okay with you shutting down the pupil. But if I can fix the problem, I took a patient with 20 broken bones in her femur or in her leg. I'm not afraid that there were 20 broken bones. I want her to run in the Olympics. Mark my words, I said, run. I did not say walk. And I said Olympics. That's my attitude. When I walk up to an accident case, I don't go up to our patient and go, thank God you're alive. I go, how do I make you run in the Olympics? So what I want to share here is attitude. We fought for it. Now, I could have not won this war. Absolutely, I'm human. But my point is, every case I do it with that attitude. I'm not going to accept defeat here. This is easy. Your hands cannot do what your mind has not decided. Therefore, I never let anybody talk about these white cataracts and hanging lenses and CTRs. Not important. Look beyond your cones. Look at the destination. Think that patient hugging you next day and you change the life after 60 years. So that's my answer, Sonu. If you can fix it, first fix it. Why leave a broken bone? And then if you have a residual issue, you humanly cannot fix it, I'm okay.
So my concern was only, putting that intact through those 24 cuts.
Not 24, this is Hex-K.
Okay.
Hexagonal.
Yeah. So,
yeah, Dr. Gaurav?
Yeah, Arun, I've really enjoyed your presentation once again. What your message is fantastic because, it's beyond, one case or a second case. It's the whole attitude and the thought process. And what I really loved about what you said was make a plan and then work towards it. Because, when you just, sometimes you have a patient lying under the, in the microscope and he just starts operating mechanically. That's not the way to go. Look at the patient, plan well. In fact, that's how we, you're going way beyond what we are doing. But, typically, like, for example, if I'm doing a toric IOL, I would love to have worked up the patient so well. I would have the eye trace, I would have the, the lens star readings and sit and see everything, make a plan, see whether the topography was right, whether I'm getting my, Placido images the right way. Because if I cannot achieve success next day, just putting a toric lens is not going to be the answer. Same way, I think, the second part I loved was how you innovate. Especially I loved the way that you put in that piggyback lens to make the patient myopic.
Yes.
In my mind that, I wanted to do a surface ablation, but I didn't know how we are going to achieve a hyperopic ablation and, get the topography right. But you managed to do that. So I think each of the cases, representative cases that you showed, the case is not so important as the message that, aim for excellence, plan for it, and then execute with perfection and make sure that you're treating a patient and not an eye, So I think these are 4 messages which I got. Fantastic for the young people. I think lovely messages, and I really enjoyed each one of them. Thanks.
Any other questions? So we can.
I have
ahead.
a question.
Yes.
In fact, I forgot. Arun, I've been seeing that you don't like to use sutures, as you said so many times. You are using that Reassure sealant for your incisions. Tell us more about it and how it works. And, I've always been intrigued because these cataract incisions, sometimes, they're leaky, and we've done quite a few things, and how you've always avoided to put sutures and how effective it is, how well it works, and how do you do it? Any tips for us?
Absolutely. Gaurav, first of all, I also haven't forgotten you had asked for some complex pterygium premium cataract case. I've kept that. I am halfway through my talk, but will depend on your time. Very important here. Again, I don't care for Reassure. Look at my language. I don't care for any technology. Here's the important reason I used it in certain cases. Now, when I say don't take stitches, please, again, take everything I say as a dictum, but of course you plan. If I have to take a stitch, and I took one stitch in this patient of Abu Dhabi, as I told you, because his intact was so close to my incision, I couldn't get out of his eye. Every time I would move the eye out, he would collapse. Now, my problem, surgery took 4.5 minutes, doing his posterior subcapsular cataract, which was subluxated in his keratoconic eye with intacts, with 19 diopter astigmatism. But I couldn't get out of his eye for 6 minutes because I refused to take a stitch. I had to take a stitch. And I took a cross stitch, but within 2 days, I took it off, brought him down to 0 astigmatism from his vision of count fingers to 20/40. So that's my question on stitch. Reassure sealant is a sealant, not a glue. It's a beautiful thing that sticks like a bandage. I have used it in these cases because in these cases, again, I want so much accuracy. And I don't want to take a stitch, but I do know the incisions is compromised because we went in twice. Remember, from the area of the intact, I've gone in twice. Again, it's not about the sealant. My mind is asking me, I want to make sure this eye doesn't change its refraction. Because what's my goal, Gaurav? I'm already in Iceland. I'm now taking off for Paris. I better not crash because the patient has bought the ticket for Paris, not Iceland. They're going like, doctor, this is cold and horrible. I don't like this. I'm like, I know, just bear with me. So it's a tremendous psychological weight on your shoulder. Therefore, even toric lenses, Gaurav, I'll show you. I've done patients of 19 diopters with toric lenses. Question is how? I do not use variant on these things. I'll show you it's a simple gadget you can use. So it's a talk for a different discussion that I don't believe in topography. I do not look at topography in refractive cases. Talk for a different occasion. Mythbusters. All of us are surgeons. All of us have a kitchen full of gadgets, correct? Everybody should get a meal. You cannot say, I put in a multifocal lens. That's why the patient is seeing. I've used multifocal lenses in RK cases for 16 years. And please take one more thing very important here from me. All my patients who are writing on Facebook or showing their photos are the most demanding and high IQ people in the world, in the most litigious country in the world. Can you imagine this? Can you imagine this for a minute? Now think about it. Your patient becomes your team member. That's what's missing in ophthalmology, I see. When I see all these complications that are flown to me by brilliant surgeons, they have no connection with the patient. The patient should become your cheerleader. I'm just there enjoying myself if you see me. They're taking pictures with you. They're going and flying their families from Paris next week. So here's the other business side of this discussion. My advertising budget is zero. Only practice in the world that doesn't advertise, doesn't do co-management. But the important thing is our patients. We have to get addicted to the outcome, not the surgery. Forget the white cataract. It'll take 3 minutes. I want every resident to be taught by you, first sentence in residency is, a white cataract is the easiest surgery you'll ever do. It takes 4 minutes. If you're taking longer, you're doing something wrong. Show them that that's not difficult. Don't call it a black cataract. Don't scare yourself. Once you pierce that cataract, it's a piece of cake. Posterior polar cataract, do a manual rexus, do a visco dissection, come out, it's 3.5 minute surgery. So what I want really to get through is not the ratio sealant. It's your desire not to add to the astigmatism or the problems. And that desire will always stand out. Same thing as I said to Samrish. He underrated his work. He said, I'm showing a different technique. Actually, he showed the correct technique. Correct direction will take you to correct destination 100% of the time. So no matter how complex these cases look, if you see, all you're doing is thinking very hard. I get exhausted the day before surgery, not during surgery. And the day post-surgery, I just dress up and show up. So the day before surgery, you take all your 15 patients and intensely plan. Intensely plan. Every patient deserves 20/20. They trust you. So does that answer your question, Gaurav?
Yeah, that does. Thank you so much, Arun. And I think, we should keep one hour specially for Arun next time, Harshul, and because we have 3 more presenters waiting and, I'm enjoying it so much, yet we move on. So I'll hand it over to Harshul. Thanks a lot, Arun, for that.
Thank you very
ideology behind the whole thing. Thanks.
Thanks a lot, Dr. Arun. Yeah.
Thank you. Thank you so much, Dr. Arun. I think it was a marvelous presentation and everybody learned a lot. Apart from the science, we also learned a lot of art, and especially we love the way the patient love you. So I think this is the way we all should go forward. And we should all...
I want to intervene that with an important statement because all of you are successful business owners. Do not sell, let them buy.
Right.
Paid doctors are refusing to get hugged by their patients next day. They're letting another doctor see them. Why? Your biggest power. You know where I learned this, Vardhaman? You've seen movies, right? You know how doctors come out of surgical suite, they're wearing glasses, they're pot-bellied, they come out and they go, I'm sorry, I tried my best. No. Change that view. Come out with your chest out going, hey, patient did fantastic. So I want us doctors, all of you are amazing surgeons. Look forward to the hug from your patient next day. That's your driver.
I think that will have to wait for a year because of the social distancing. That's the only thing we'll get between us having the patient now. But the concept, it's a very good message that you've given. Passion for making your patients happy and coming out with being a successful surgeon. I think relate to the patient. That's what you're trying to say, and that's wonderful. Thanks.
Thank you again. And I think with the time at hand, we will have to again move forward. to the next presentation. Thank you again, Dr. Gulani, for such an inspirational presentation. I think next in line we have a very close friend, Dr. Somil Kothari from Mumbai. He is the medical director of Bombay City Eye Institute, a very prolific cataract surgeon and refractive surgeon. He has been trained in JJ Hospital, Arvind Eye Institute, and many places around the world. And here too, Dr. Somil for his presentation.
Thank you, Vardhaman. And thank you, Harshul, for having me out here. And really enjoyed Dr. Gulani's talk. Thank you so much. So my talk, I'll be just sharing my screen. Can you see it?
Yeah.
All right. So I was asked to talk on this topic of subluxated cataract made easy, step-by-step approach. Now we all know that many surgeons consider subluxated cataract to be like the final frontier in cataract surgery, one of the most difficult cases to treat. But how do we ensure success in such tough situations? What I mean by success is not just removing the lens and placing a scleral fixated or any other type of lens. What I mean is that how do we place a posterior chamber intraocular lens in the bag in such tough situations? That's what this whole talk is going to be. Giving the best to the patients, as Dr. Arun said, is of paramount importance. It starts with the preoperative assessment, and we note the degree of subluxation, the grade of the cataract, whether it's soft or hard, the pupil size, and the presence or absence of comorbidities like iridodialysis or vitreous disturbance or any other such conditions. When we examine them on the slit lamp, many times in the undilated state or even in the dilated state, we do see that there is a presence of discontinuity of the pupillary slit at the level of the pupil and at the level of the lens surface. So we have to be aware of that this is going to be a slightly different situation than a normal routine cataract. Going to the surgery, although we tend to think that our subluxated cataracts are quite different and unique, but definitely what I have noted in doing many such situations is that there is a common thread that binds all of them. Taking it step by step now, let us see. The first step is about scleral preparation. Normally what we would like to do is we cut open the conjunctiva and create a scleral flap for the ultimate position of the suture to be buried. But now, since 2006, Dr. Richard Hoffman has showed us that you can definitely make a much better way to bury the knot, that is to create a Hoffman pocket. Now, what the Hoffman pocket is basically it's a scleral pocket, and we initiate the pocket by making a limbal groove, like how we make in our limbal relaxing incisions, the LRIs. Please do note that it is very important to use a diamond blade, which makes things much easier. We are all used to doing SICS, manual SICS, where we go from the scleral side to the corneal side. This is like doing a back dissection, right from the cornea to the sclera. So we make a subscleral pocket. That is what Dr. Hoffman said. We leave the pocket aside for now, and then we go on to the next step of side port creation and vitrectomy. Of course, only if it is required. Case-to-case situation is maybe different. We stain with tricot if necessary to aid our visualization of the vitreous, and we do a limited anterior vitrectomy because we do remember that the vitreous is also supporting the cataract from behind. Next, we stain the capsule with trypan blue, but before we do that, we plug the gap with dispersive OVD. This all aids in, again, a visualization, which is very, very important. Even though you may be able to do a rexis without the aid of the stain, in such difficult situations, it's of paramount importance to stain and make our life simpler. Doing the capsular rexis is the central key point in this whole surgery. If you manage to make a capsular rexis, you've won half the battle. So what I would stress is take your time in doing this step. We start we aim our forces towards the area of subluxation so that we don't aggravate it. And then gently and carefully, we make a small, it should not be too small, it should not be too big, ideally 5.5 to 6 millimeters in size. We do a central capsular excess. Sometimes there is a presence of an anterior capsular plaque, in which situation we may need to use different techniques, like here I'm using the vitrectomy cutter to just get through the plaque, and then I continue with my rhexis. Sometimes in cases of very severe subluxation, it may be very difficult to even initiate the nick and propagate the rhexis. So in such situations, like in this case, after I make the initial nick and then I make a small rhexis, I need to add to the counter traction with the iris hooks or capsule hooks as the need may be, and then I complete my rhexis. This is a very, very important step in the whole thing. And of course, in the advent of femtolasers, we can just simply go ahead and create a laser capsulotomy. And this is where one of the cases of femtosecond, this is an indication where the femtosecond laser really helps and comes to our rescue in creating a good rhexis. The next step is to stabilize the bag. The use of iris hooks or capsule hooks is very important. After you create a good rhexis, we stabilize the bag vertically. What these hooks help is when we hook it up, we tent it up, and we create a vertical stability to the whole capsular bag. Also, after we hook it up, I implant the CTR. I tend to implant the CTR earlier. This expands the bag horizontally and it gives a horizontal stability. So the hooks give us vertical stability and the CTR gives us the horizontal stability. Once both of these are in place, we can have a good stable bag. Sometimes you need more than just a couple of hooks. We need the entire bag to be stable. And once the bag is stable, we go ahead with the nucleus management. And mind you, we need to lower down our parameters if need be. And let me assure you that once the whole bag is stabilized with the hooks and the CTR, it becomes more of a sort of a normal case for you. And you can definitely go ahead, although slowly and steadily, and using good machine, good parameters, we can ensure that the chamber is quite stable. After the nucleus is removed, to remove the cortex with the CTR in place becomes slightly tough. We may resort to use a tangential maneuver. That is, we don't just strip the cortex radially, we do a tangential force so that the cortex comes out very smoothly. After the whole bag is empty, we plan for the fixation device and the length and the IOL. Here I'm using a Sioni's ring with an eyelet. You may use an MRCTA capsular tension segment. This is where the Hoffman pocket comes into play. After using a 00 proline, 10-0 or 9-0 proline, we can absolutely go with the one arm of the proline through the Hoffman pocket. The second arm goes through the eyelet and goes again through the Hoffman pocket. So essentially you're looping in the eyelet in the area of maximum subluxation, putting the lens, retrieving the sutures. You cut off the needle, you retrieve the sutures through the limbal incision which you made, and you titrate the strength of the sutures so that the lens is ultimately right in the center. Right? After you cut the sutures off, the knot just slips back into the subscleral space. That's the beauty of the whole thing. And after you place the IOL, you can just remove the OVD and that's the end of your case. Here you can see this fantastic results because you're not opening the conjunctiva, the post-operative discomfort and the cosmetic appearance is very, very pleasing to both you and the patient. So just, and of course, we need to manage comorbidities. If there is an iridodialysis, you need to have an iridodialysis repair. And that's what I want to say about this situation. It's very easily managed. You can see that after, what I want to say is the summary of the steps. You create a Hoffman pocket, triamcinolone assisted vitrectomy if need be. You stain the capsule and put a dispersive OVD. Doing the rhexis is of paramount importance. you put in hooks plus or minus CTR, go ahead with your phaco and cortical aspiration, and then you go and put in your Ciones or an MH segment and the lens. So these are the steps. So keep calm, follow the rules, and definitely you will come out as a winner in this whole game. Thank you so much.
Thank you so much, Somil. I think it was a wonderful and very systematic approach to a very complex scenario. A lot of us do perform a lot of sublux lenses, and a lot of general ophthalmologists want to learn. And I think this was excellent, let's say, systematic approach that you have shown. Very quickly, I think we would like to have two people giving their own concepts about it. I think to begin with, if we can ask Dr. Sandeep from Jaipur, if he wants to chip in.
You need to unmute yourself, sir.
Just unmute, Dr. Sandeep. Yeah.
Yeah.
Can you hear me?
Yes.
Yes.
So this was an excellent presentation, Dr. Kothari, and you have shown an excellent way of how to tackle this difficult situation of subluxated cataract. I think we must go for another speaker now, or should we discuss some points here?
Probably we can have one quick, let's say, point shared by
Dr. Sonu.
Would
you like to add something?
Yeah.
Any tips for?
I think Somil demonstrated very nicely how to handle a subluxated. That was really a wonderful presentation. Just a quick word about the suture material to be used, because these days I'm using Gore-Tex, Ato Gore-Tex. So I think on a long term, looking to the decay that we've been doing these cases 10 years down the line, and we have found that these lens back complex getting subluxated again. So I think a Gore-Tex could also be one of the ways to chip in these subluxated cataracts, getting them fixed. Wonderfully described, Kamil.
Great point.
Thank you.
Yeah.
And I think at the end, Dr. Arun, if you want to add any point here.
What is the vision, Somil, of this patient?
Well, the vision, I've shown many different situations with different patients, and most of them, they improved to 20/20 or 20/30. I've put in a toric lens as well in certain situations where when they were indicated, and they've all done very, very well, and they were very pleased. In fact, they keep on coming back and really thanking that in spite of such a they do understand that this is not a routine situation. So, and they were very appreciative of the fact that there's a good job done.
As long as the vision is reaching that level, Somil, very proud of you. Yes.
Yeah.
Thank you.
Yeah, Dr. Sandeep, next.
Yeah. Now the next is Dr. Janin Patel. She's from Mumbai, and she's a prolific surgeon. And topic is dealing with unfavorable situation for a favorable outcome in premium IOLs. Dr. Janin, please. Dr. Janin.
Good evening. Yeah. Am I audible?
Yeah.
Yes.
Audible.
So, is my screen shared?
Not yet.
Not yet.
Now?
Yeah.
Yeah, we can see now.
So I'm going to be showing some routine cases that we see in everyday life, and complications really don't need a complicated case. So this is a routine brown cataract, and when I'm just going ahead with emulsification of the pieces, and I reach the last piece is where I suddenly feel there is some subtle changes in the dynamics of the anterior chamber. That's the time I want to stop. Do not want to continue with my phacoemulsification, and definitely not withdraw the probe in a knee-jerk reaction. I want to start developing a little bit of my clarity of the mind. So I remove my chopper, go in with a dispersive viscoelastic, make sure that I stabilize the chamber completely with me being in the irrigation mode. At this stage, I want to now make sure what exactly has happened. Don't want a sudden collapsing of my chamber, because that may tend to lose the pieces into the vitreous cavity. I, with another instrument, would secure the vitreous cavity, the pieces over the iris plane, and with a tricord, try to enhance how much of, visualize how much of the vitreous is actually prolapsed and what exactly is the situation then. and then plan and strategize the next plan of movement of how I want to take it further. So go ahead with an anterior vitrectomy since there was a little vitreous at the wound, and then switch to the posterior vitrectomy. Now, the reason for changing and going towards a pars plana vitrectomy is that you do not want to enlarge the tear. You don't want to lose the pieces to the posterior cavity. At the same time, I want to minimize the amount of the vitreous loss that's happening. This is definitely the more physiological process to go ahead. At the same time, you're pulling back the vitreous back home. So it is definitely going to help in compartmentalizing the anterior as well as the posterior chamber. I go ahead and use my IOL and dial it into the bag at this stage. The reason for doing this would be the scaffold is going to help me in two ways particularly. One is it will not let the vitreous come to the probe. And second, it will emulsify the nuclear material and not let me lose the nuclear material into the vitreous cavity. Post that, I can go ahead and do a cortical aspiration of the case. And this is the slit lamp photograph on post-op day 1. And the results are as good as an uneventful case. Now, this is another case which I would be sharing where the patient has a relatively soft cataract. I'm going ahead and this is possibly the space where it happened. I'm too much in the periphery. I have missed it then completely. I continue doing my phacoemulsification. I bring out the second nuclear material from the anterior chamber. And after the piece has been emulsified, there is that possibly I've had an inadvertent opening. It's better to have an early recognition than be in denial in such cases. I also have a choice whether I want to switch to SICS or continue phaco. I choose to continue phaco, definitely changing all my parameters. So I go down to a low phaco parameters with my vacuum aspiration and power and an IOP setting of 24. Make sure I do not have any fluctuations in the anterior chamber. The chamber is always at the positive pressure so that my vitreous does not prolapse anteriorly. I do not want now, when I'm removing the probe, you can see a little bit of the rent which is extending. I continue keeping it in the irrigation mode there. Go ahead with a dispersive viscoelastic and plug the opening that is completely there. Now, I still have a lot of nuclear plate which is remaining to be removed. So here we can use the bimanual IA intermittently. If you have a vitreous coming in, you can switch to the vitrectomy mode and the IA cutter mode. Make sure you completely clear the vitreous. Use your triamcinolone to see exactly what's happening. What's important here is the main goal of your surgery is if you have started with a small rent, at the end of the surgery, your rent should not increase or move towards the periphery, and you should be able to carry out an in-the-bag IOL implantation. So this is very important that you recognize it earlier and do not let it proceed. But like I said, you can have a complication at any stage, and you're not really done till you're done. So at this stage, I'm almost finishing. I'm just doing a capsular polish, and here I realize that I have a small capsular tag that has come in. Now, if I leave it like this and go ahead with the IOL implantation, there is a possibility that it might extend into the periphery. And I also have a back complex, which is unstable. Go ahead and complete it into a PCCC. And once I complete it into a PCCC, it's going to give me a more stable capsular bag support. Also, the problem at this stage is I've got an intraoperative meiosis that's come in. So I also need to deal with it. Now I'm using a preloaded IOL, and unluckily, like I said, sometimes the situations are unfavorable. I ended up having the trailing haptic breaking. Now I have an open posterior capsule, and I need to have manipulation in the chamber to explant this lens. For editing purposes, I haven't showed the vitrectomy. However, I've gone ahead and implanted another lens. Now, a surgical tip is you can use an iris hook. Just withdraw one edge of the iris so that you can see the capsular edge and dial the lens into the bag. You do not want too much of dialing, but the lens can be implanted in the bag. So my take-home message is suspect it even if you don't see it. Recognize early denial is the worst thing to happen. Use dispersive viscoelastics to plug your pore and tampon out the vitreous. Minimum manipulations and chamber fluctuations with low parameter phaco. triamcinolone assisted vitrectomy is important, and pars plana approach is now a necessity for every surgeon to learn. Thank you.
Thank you very much. I think, Dr. Janin, it was a wonderful management of very complex scenarios. I particularly like the way you have used the iron as, let's say, to compartmentalize and then to make the surgery more safer. I think we will have probably a couple of good opinions from two panelists. I think probably Dr. Deepak can let us know what he thinks about the surgeries and anything differently he could have done.
Yeah, congratulations, Dr. Janin. I think it was wonderful. You did it very
I think, Janin, if you can stop sharing your screen.
Harshul, I'm unable to.
Yeah,
yes,
okay.
yes.
You did it now.
Okay. Yeah.
I think that was a wonderful demonstration of your technique, and I think every point of it was meticulously done. And what was the bottle height when you do vitrectomy? Do you have any?
So usually I have a Centurion. So on my Centurion, my IOP settings regularly on a routine basis is 24 to 28. So I do work on lower IOPs, and I keep my cut rate at the maximum and the lowest vacuum, which I need to bring about safer aspiration. So I go down on all my other parameters.
Yeah. Just to get one point across here, that even people are using gravity-based system. When you're doing a vitrectomy, even if it's a pars plana, if your infusion is too high, if the fluid is coming with a lot of pressure, you can still increase the posterior capsular rent. So you need to monitor and titrate your infusion pressures, irrespective whether you use an active fluidics or a gravity-based fluidics. I think when we have PC tear, I think the message should be that always try to monitor the infusion rate. That itself can extend your PC tear. That aspect is not usually touched upon. Usually they say work on high cut rate and low vacuum. But one important point to take home here is that, always watch out your infusion. You do nothing, just the bottle height, raised bottle height itself can blow the posterior capsule, irrespective whether your route of entry is anterior or posterior. Thank you.
That's an excellent point. Thank you, Dr. Deepak. I think we would like to also know from Dr. Gulani about his approach.
I think surgery was very well done. As long as the vision has reached this point, excellent. Only comment I would have is, when you had that incident of the posterior tear and your lens was, the haptic was broken and you had to exchange the lens. What I would have done is I would have put in the second lens in under that and then started working. This way I have zero fear. I don't care what happened at that point. That's the only thing I can interject from my side.
Yeah, actually that's a very nice point. But I think in this particular case, my intraoperative meiosis that was there was probably advantageous in that aspect where it helped as a scaffold and it didn't, cause too much of chamber fluctuation. Had I had a completely dilated pupil, maybe it was an easier thing to do is what I feel. But yeah, I take your point.
Correct. In fact, the pupil being small makes it very clear that there is no other option. I would have put it in the lens because you can't see anything at this point. So I would, in fact, make it absolutely sure that the lens would have gone. And this is for other people. Maybe they don't have the skills you exhibited here. But if the pupil's coming down, what you want is a diaphragm that you, even if you cannot see, you're 100% confident. So it would maintain your posterior rexus, the posterior capsular rexus that you did. Lens in place, pupil comes down, no big deal, because this lens is up in the anterior chamber anyways. And you're cutting it up, whatever, bringing it out, right? Yeah. Excellent job.
The principle of scaffold makes the surgery really safer in this complex scenario. Excellent point, Dr. Gulani. And is there any other point any other panelist wants to make?
I think we move on to the,
last one? Yeah.
Yes.
Sure. So I think, yes, so basically we have had excellent presentations. The last one is from a very top-notch surgeon. We all know Dr. Sonu Goyal. He is recently got elected as the scientific committee member of All India Ophthalmic Society. He is a very prolific cataract and refractive surgeon. He is, of course, practices in Jaipur. Everybody knows him, and is a very prominent figure in all international meetings, including ESCRS. So we would like to invite Dr. Sonu Goyal to show his presentation. Thank you.
Thank you, Vardhaman, for the nice introduction. Now I'll take a small leverage because Dr. Gulani has, inspired to have something which is like 2020. So let's see on board how 2020 works for us. So Is my audio and video audible?
Yeah. Yes.
Yes, they are audible.
Yes, it is.
Vardhaman?
I think
audible, please?
Audio is not that much audible. I mean, we can hear what you're saying, but if there is integrated audio in the video, I don't think it is audible.
Am I audible, please?
You are audible.
Yeah, you're audible.
You are audible. You are audible. Yeah.
Okay, I was not getting the sound, so I'll just have to repeat. Just give me a second. Okay. So let's see what 2020 for us stand for. This 25-year-old gentleman came to us, and you can see here there is a breach. There was sealed corneal tear here right in front, and a careful slit lamp examination, there is a break in the anterior capsule as well. And what is more interesting is a break in the posterior capsule. So there is a pre-existing posterior capsular defect. Now this is the view under the microscope. Now the dilemma to deal it anteriorly or posteriorly. But yes, definitely, Dr. Gulani says give him 20/20. So I had to resort to go to the anterior route. So I make 2 side port incisions, 1.1. The plan is simple: to make a capsular access to include the breach in the anterior capsule within that capsulotomy. So I designed this capsulotomy, a large oval enclosing this breach in the anterior capsule. And yes, this is a 25-year-old gentleman, so I know there is no nucleus. So I would be able to aspirate the cortical fibers all 360 degrees. So the plan, all decided, pre-planned, go in, make a small nick and put in a viscoelastic, and I fashion a capsular access using my microcapsular access forceps. Now here I go ambidextrous, fashioning the capsular access till down the line this. I switch on to my left hand and just watch very carefully. I'm trying to fashion to include this break in the anterior capsule so that I have a perfect curvilinear capsular access, which is continuous all 360 degrees. Half of the job is done. Now look, I put in the irrigation aspiration. My irrigation in the left hand is right on top. So I am preventing the fluid from going behind. I don't want the misdirection to have here. And at the same time, I'm trying to use the 360 degree sweep, I call it. I'm trying to hold and pull these capsular fibers radially in the center. So I'm trying to create a sort of sausage, which I can pull at the end in, and I freed all the cortical matter. And look, there is the large break on the posterior capsule sitting right there behind. And yes, I'm done. Now watch, my irrigation goes on top of the iris. I don't want the vitreous to come in. I push in the dispersive here because I want to do a clear compartmentalization so that the vitreous doesn't pop in. Successfully, I have been able to do it. So now again, a debate whether to do an anterior or a posterior vitrectomy. There is hardly any vitreous. So I do triamcinolone staining routinely, go in and just clear for any vitreous tags, residual leftover. Now the plan is simple. I want to convert this break into a much stronger post-PCC. So I try and fashion grasp, and I fashion it into a complete 360 degree rexis. So this PCC would now give me a much stable lens back complex. Residual vitrectomy for hardly any tags if they are, and a 3-piece hydrophobic acrylic foldable IOL would be a choice here. So I slowly use the injector delivery system, push it directly inside the bag, very slowly dial this 3-piece inside and watch. I would do a capture here, and the lens optics go behind the posterior capsule, and the lens back complex looks quite stable. Residual viscoelastic wash. I would always use an intracameral Vigamox at this stage because it's trauma, it's an open bag. And to hydro stitch very carefully, my left hand irrigation is on. I don't want the bag to go shallow because the moment the AC shallows, the lens might pop out where I've captured. So very gently, I keep the AC maintained, just withdraw, and then being ambidextrous both ways, I'm able to hydro stitch the wounds. And this is the day one picture, crystal clear cornea, pupillary axis clear, and the patient 2020. Thank you, Dr. Gulani, for teaching us all this. And I think it's the attitude which is very important.
I loved your last part, Sona.
And I love the whole part of it. Yeah. Wonderful surgery, Dr. Sonu.
Wonderful, wonderful surgery.
Yeah. So
Fantastic surgery, Dr.
Yes, very nice.
Dr. Somil, you want to add something?
No, as usual, Dr. Sonu lives up every time to his name, to his repertoire. That very well done, very well planned. That's more important, and an excellent job. There's nothing to add.
Yeah. So,
Dr. Sonu,
I'll have a quick question
Yes.
to Dr. Arun.
Dr. Arun is asking.
Yeah. What is the energy drink that you have?
I'll tell you one thing, Sona. Again, it's a pleasure speaking on such a panel because you guys are such amazing surgeons. So I really feel the energy is the feedback of your patient. I truly believe doctors are avoiding that energy by just showing up in surgery and doing 20 regular cases and going home to play golf. It doesn't make sense. It does not make sense. It's your office. If you like purple color, make it purple. It's your office. If you like a different music, put it there. But that's just sort of my take on it. I mean, the surgery you did should be exhilarating to you because you changed someone's life. You did a beautiful job there. That's your energy.
Correct.
So we have many questions coming up on various platforms. So is a question from Dr. Bhushan Ghodke to Dr. Arun Gulani. First, he compliments you for your talk, and he says that we want to hear more from Dr. Gulani. And then he asks that why we did not do scleral phaco instead of clear corneal phaco with a sealant in a patient who had Hex-K.
Why did we not do?
Why we did not do scleral phaco instead of clear corneal phaco with a sealant in a patient with Hex-K, which you showed.
Absolutely. Again, if you notice, I like to keep things simplistic. And that corneal incision was very easy to do because it was away from my intact, which was closer to the center because the hexagonal keratotomy has a 5 millimeter zone. You see how each case is different. This is not RK. Hex-K has a 5 millimeter zone. It's a spiral Hex-K. If you know, there are incisions across that makes the central iron unstable. So I moved my parameters for the channel just outside that, but still far away from cornea. Remember, I'm still planning Paris. I cannot jeopardize my cataract surgery. Therefore, I was confident to go through the cornea. And I want, again, everything I do is simplistic. I don't want to complicate things. Even if the cataract subluxated, I don't care. I don't think about surgery. So that's my philosophy. If it's the way I have planned it, I took my steps, I flew the route I had planned from Iceland to Paris. I didn't change it.
Perfect. So one more question from Dr. Bhushan Ghodke is, do you recommend pars plana vitrectomy even for a surgeon with a phaco machine with lesser cut rates? I think Dr. R.K. Sharma, who is a retinal surgeon, can take this question.
You'll have to unmute.
Dr. Harshul, pars plana is the route for doing the vitrectomy. See, sometimes when you don't have the vitrectomy machine or you don't have the pars plana approach available or you don't know or you don't feel confident, yes, you can manage to do it through the antechamber itself. But pars plana is the route of choice, no doubt about it.
He's asking, do you recommend for a surgeon with a phaco machine with lesser cut rates?
It doesn't matter. The cut rate is going to be the same, whether you go through pars plana or you go through the limbus. It doesn't matter. It doesn't matter.
So what
the cut rate should be, as far as possible, it should be as high as maybe 5,000, 3,500 or whatever. But it doesn't matter. The pars plana is better.
Routine phaco machines have cut rate of around 1,000 to 1,500 only. Routine phaco machines. So can we go vitrectomy, pars plana vitrectomy with this cut rate?
Yes, you can. Yes. You can. The only thing is the risk of the traction on the retina increases. The chances of creating an iatrogenic tears increases. I started doing vitrectomy when the cut rate, maximum cut rate available was 400 cuts only, way back in 92. Yes, the incidence of retinal tears was high, but nowadays you have 10,000 cuts also available, and maybe in near future you will have an ultrasound vitrectomy also available. So it depends, whatever is available, you must use your highest cut rate and minimum suction.
That's right.
Fine.
I think we have one question from Dr. Shishir Agarwal. So he, yeah, and he's asking question to Dr. Deepak Magur. He's asking about his sutures, whether the sutures were full thickness, and if they were full thickness, were they removed also in OT or they were removed on the slit lamp?
They were full thickness and they need to be removed in the operation theater itself. So
yeah, I think that is a very important point for everybody to
going
understand.
into the antechamber, I wouldn't want to risk it at the OPD.
Absolutely.
There is one question from Dr. Siddharth Kothari. He's asking, what is GPS?
Gulani.
Dr. Gulani, Gulani positioning system.
Gulani planning system.
Planning. GPS, as you know, is all of us know about GPS. The concept here is very important. You saw the first case I showed you where I had to reverse the 12 surgery. That was wrong GPS. Brilliant surgeon from New York. Wrong GPS. Went to all the wrong turns. So they did ICL in a keratoconus without the cornea being stable or measurable. So obviously it's going to be wrong vision. Then they did Intax after putting ICL. Intax is not an accurate surgery. It's an anatomical surgery, topographic surgery. So see how you have to think. So even though the surgeries this doctor did, and then they did cross-linking, which is totally wrong because now they're linking a permanent defect. So the GPS was so wrong in that case. The GPS I showed you going in my case forward showed you how we are planning. So that's what I mean by GPS. It's not just surgery, how you're planning your stages. And I call this sometimes simply outside, inside out technique, meaning you never want to enter the eye if the cornea is not measurable and stable. Otherwise, you're doing a disservice to the patient. You're just shooting in the dark. And you want to plan the outside to go inside. Sometimes you plan inside. I go inside with a toric lens and I create astigmatism in a scar cornea in a predictable fashion. So a scarred cornea has, let's say, an axis in this direction causing 8 diopter astigmatism. But the patient has a dense cataract. Now, this is too deep a topic. Next time, I put in a toric lens, I change the axis. Now my laser, which works on the flat axis, the vis axis, gets the whole scar. So see how you can play. And the surgery is very simple to all of you. But the thought process, that's GPS, direction.
Yeah. Dr. Sunena? Yeah.
Yeah. Dr. Arun, this is for you. If for nothing else, I think I'd love to come to you as a patient for your dress sense, because that's a
So there's a question for you, Dr. Vardhaman. Dr. Mohak Shah from Ahmedabad, he asked that, would you suggest to put BCL after all your smile surgeries? He puts in all of his smile patients, and he says that he has not seen much epithelial ingrowth after that.
So I don't, so I don't put BCL in any of my smile procedures, frankly. And in my own series, I think I've done close to 3,500 smiles, and I have only one inoculous epithelial growth. So I wouldn't really say, because BCL itself can be a, let us say that it can be it can create biofilm for the future infections and another foreign body in the eye. So it is, when it is not required, I don't use it. But of course, if I have an epithelial defect, then I will surely use it, because it will help epithelial healing, as well as it will decrease chances of DLK as well. So
fine. So I think with this we come to the end of today's webinar, and once again I'd like to thank our guest speaker, our star speaker, Dr. Arun Gulani, for joining and staying with us for this 2 hours. And it's a great pleasure to hear you, Dr. Gulani, and to get inspired from you. And we have learned a lot of attitude, that we should have thought process and good attitude to bring 2020 and more than that to all of our patients. So thank you very much, Dr. Arun. And we will definitely like to have you for 1 or 2 hours speaking only Dr. Arun. Yeah. So, and thanks to our President, Dr. R.K. Sharma sir, Dr. Sandeep for allowing this unique thing. And Dr. Sunena ma'am, President MOS, Dr. Vardhaman, Dr. Preetham, and to all our speakers, Dr. Gaurav, Dr. Somil, Dr. Deepak Megu, Dr. Janin, Dr. Sora Patwardhan, Dr. Sonu Goel. So it was a great pleasure to have all of you with us today evening.
Yeah,
So,
and
thank you, Harshul, for having this done.
Yeah, and from MOS also, we would like to thank Rajasthan Ophthalmic Society on behalf of our President, Dr. Malik ma'am, and all our team. It is very wonderful to see that we have crossed 2,000 plus viewership for this webinar. So it has gone across the world. So basically, apart from India, where we have maximum viewership, we have second viewership from US, and the third is UK. So I think we have it has been truly international and global webinar. We would like to again thank all the speakers, and thank you, Dr. Gulani.
Thank you, Dr. Gulani.
Thank you. Stay safe.
Thank you, Harshul.
And Harshul, Dr. Harshul.
Thank you, Harshul.
Yes.
Harshul Vardhaman, Naina ma'am, thank you.
Bye.
Congratulations.
Pleasure.
Bye, Arun.
Thanks, Dr. Arun.
Bye.
Thanks.
Thank you, Dr. Arun, for that
Bye.
wonderful.
Take care.
Bye, Dr. Arun.
Love you guys.
Take care, everybody. Thank you.
And
Bye.
Harshul and
Thank you, Sunana madam.
3 cheers.
Bye, guys. Bye.
Bye.
3 cheers to everybody.
Bye, sir. Bye, sir.
Yes.
Bye,
From
Somil.
our
Bye.
own surgeons.
Bye.
Please remember that. Not to take anything away from our own surgeons. No offense intended, Dr. Arun. You are great. But I think our surgeons are also terrific.
He's one of our own man.
He's our own man. He's from KM.
I know.
He's one of us.
I think before we go, we would like to see the beachfront, Dr. Arun.
Yeah.
Because we have not gone out of the house for last 1 month, no?
Right.
Even Mumbai people they haven't seen the beach.
I can't promise you the bikini clad one today, but
yeah.
Oh, it's so sunny there.
Yeah. Oh wow.
Beautiful.
Wow.
We can see that. Yeah.
Beautiful. Florida Beach. Amazing.
Dr. Gaurav? Yeah.
Yeah, I'm back.
Hi.
Yeah.
Thanks, Dr. Gaurav.
Yeah, no, really enjoyed it. I had to just go out for a quick Zoom meeting.
Oh, wow.
So I'm back, and really enjoyed it.
Beautiful garden.
Arrangements
There's a beautiful garden there.
Yes.
Yeah, that's all we have in Dehradun, So good weather and good greenery. I had Arun is there, and I was having a doubt, and he could help us because we are going through this whole process of how we are going to operate for
Rahul,
cataract.
it's still online? Or
Is Arun still there?
Are we offline now, Mr. Rahul?
No, Rahul?
Yes, sir.
Can we just stop the online sharing?
Let's leave the meeting.
Yeah, we can leave the meeting. And
Let's leave the meeting and reconnect, guys.
I thought I'll ask Arun about how they plan to start surgeries and whether they're going to do COVID tests for their patients, because he likes to hug his patients and they're always with him and close to him, and he's talking. He's like walking through it. Huh? So I don't know if he's still around, but I think he's
there. Yeah,
Arun, are you there?
Yes, Gaurav. Actually, today we are having a meeting on that. It's very difficult. All patients will have to suspect unless proven. So we're deciding to take temperatures, and then all staff will be tested. And we haven't yet decided the date to reopen. Have you guys opened that?
So, we are still under lockdowns. Some places have opened up where there have been no cases, but where there are still cases and they're growing, we are still under lockdowns. And there are conflicting reports, like some states are saying you keep your clinics open and keep working. And other states are saying if you open, we'll come and shut you down. So, and the other main thing is that especially if we want to do any LASIK or cataract or something, because it's been a month and a half since we've been under almost more than a month that we are under lockdowns. So, whether to start cataracts or not, how risky is it, whether we should be doing COVID tests or not, like all those questions. I thought, getting the US perspective might be good to hear, like what you guys are thinking.
Everybody here is also confused. Nobody's clear, but I think the protocols I want to take is the whole staff we're going to test in